and I'm coming to you from Toronto and acknowledge that Toronto is on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. I also acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaties signed with multiple Mississaugas and Chippewa bands. I am so honored today to be able to introduce to you the Honorable Senator Wanda Thomas Bernard. Senator Bernard is the first African Nova Scotian woman to be appointed to the Senate of Canada, representing the province of Nova Scotia and her hometown of East Preston. Senator Bernard champions issues impacting African Canadians and people living with disabilities. She's particularly interested in human rights, employment equity, and mental health. Through her involvement in community projects, her social work career, her time with Dalhousie School of Social Work, and now her work in the Senate, Senator Bernard has maintained a deep dedication to social justice and racial justice. Senator Bernard advocates for reparations for the historical and continued anti-Black racism impacting the lives of African Canadians. So it was over to you, Senator Bernard.
Thank you very much, Louise, for your introduction, your kind introduction, and thank you for inviting me to join you here today. I'm really pleased to be able to share with you on the topic of future of culturally responsive care for Canadians. So congratulations to the organizing team for organizing this very powerful summit and creating space for this topic to be included. We'll go to the next slide, please. I'm joining you from my hotel room in Ottawa this morning, and I'm grateful to be here on Anishinaabe Algonquin territory. So I want to talk a bit about anti-Black racism in healthcare, and then highlight culturally responsive care, and then how do we create systemic change and the need for the creation of braver spaces to make that systemic change, to make those systemic changes happen. We'll go to the next slide, please. So when I think about, and you have to hit that a few times to get all of my points here. So to talk about anti-Black racism, it's a topic that most Canadians, quite frankly, don't want to talk about. But it's really about it's prejudice, it's stereotyping, it's discrimination, it's that active beliefs and attitudes that portray people of African descent in a negative light. It's racism directed at people of African descent, rooted in a history of inequity, a history of missed opportunities, a history of enslavement, a history of colonization. Anti-Black racism is so deeply embedded in all of our Canadian institutions, policies and practices, including in healthcare. And from the work that I did with colleagues looking at racism, violence, and health, we talked about and uncovered anti-Black racism, named it as a form of violence, and as a form of violence that impacts the health and well-being of African Canadians. And that research project was done with African Canadians in 3 Canadian cities: Toronto, where many of you are today, Calgary, and my hometown of Halifax. We'll go to the next slide. when we look back in history, we can see the roots of anti-Black racism in medical care. So one of the stories that pops up when you think about anti-Black racism in medicine is the story of Queen's Medical School banning Black students. Other Canadian medical schools had similar policies. And, you know, that history has contributed to what we're seeing in medicine today. And it's taking decades and decades to change the trajectory that was started because of those early roots of anti-Black racism in medicine. We'll go to the next slide. Policies that kept people out. And then we've seen this move into anti-Black racism in healthcare. And anti-Black racism in healthcare contributes to, leads to, compounds health disparities. And if there was one thing that happened during COVID, it amplified the health disparities. And we could see the anti-Black racism and other forms of racism as well. But my focus today is on anti-Black racism. So when we think about anti-Black racism, we think about individual racism, but we also need to think about cultural racism and structural racism. And they all have an impact. They all have an impact on health and well-being. And now, just as a few years ago, Health Canada is now including racism as a social determinant of health. But of course, people of African descent in this country have known that anti-Black racism is one of these social determinants of health. We'll go to the next slide, please. So when we think about that individual level, it's the stereotypes that can lead to misdiagnosis. It can lead to assumptions that lead to misdiagnosis. It can lead to a subpar healthcare. It can lead to very biased treatment. If I had more time, I could share with you so many stories, personal and professional stories, of anti-Black racism in healthcare and the health disparities. And at that individual level, one of the things that we know needs to be really solid is the communication between a patient, a client, and the healthcare services provider. And when anti-Black racism is at play, that communication lacks the quality that's needed to ensure that individuals receive culturally responsive healthcare. We'll go to the next slide. When we think about anti-Black racism at that cultural level, if you just think about there's so much research that highlights the racial disparities in healthcare and the cultural racism that underpins and breeds and helps to fully embed that anti-Black racism culturally in our this ideology of inferiority. And when you see people as inferior, you treat them as inferior. And the unconscious bias lives within us, and then we act upon it. And that contributes to health disparities that people of African descent experience in this country every single day. We'll go to the next slide, please. And if you think about the structural level, we're in the last year of the United Nations Decade for People of African Descent. But when the rapporteurs from the UN came to Canada, the structural racism was one of the areas that they highlighted in their study of our experiences here, the experiences of Black Canadians. And in their statement, they talked about the impact of structural racism on Black Canadians, and the fact that change is only going to happen when we do something about it. We need to create changes in the healthcare system to reduce the health disparities and then thereby improve the health outcome for Black Canadians. We'll go to the next slide, please. So if we think about that structural racism, one of the things that we've seen, of course, if you look at the representation, there's an underrepresentation of Black people across healthcare fields, in medicine and nursing and social work and healthcare, and all of the other allied professions, physiotherapy, respiratory therapy, any of the fields you see this underrepresentation. And there's also this underrepresentation in terms of research and publications in academic journals. And so where do people learn? Where are people learning, and what are they accessing? And if there's very little published research on issues, health issues impacting Black Canadians, then we will continue to see generation after generation of healthcare professionals not being adequately prepared to work in our communities. That's the structural level. We'll go to the next slide. So how do we change things? How do we shift things? How do we get to a place of culturally responsive healthcare in our healthcare systems from coast to coast to coast? What do we need to do? On the micro level, we can look at how do we change and improve interactions between healthcare providers and their patients. We have to work at that level. At the meso level, how do you do better? I think you may have some folks from Nova Scotia joining you today. The Health Association for African Canadians, HAWC. They'll talk about some of the wonderful work they've been doing at all of these levels. In terms of primary care, they now have there's a brotherhood, Black Men's Health Services, and a sisterhood, Black Women's Health. And they're doing some really creative community health programs that are making a difference and will continue to make a difference. At the macro level, seeing changes in health systems, seeing changes in healthcare boards, seeing changes that you have people who are making decisions. You have people at those tables who bring that lens of a culturally responsive healthcare system, a roadmap that will help us to get there. And then at the mega level, we're seeing programs right across the country, including Queens, a medical school, a program set up to help encourage and support more Black students to pursue medicine. University of Toronto has a similar program. Dalhousie University in Nova Scotia has a similar program. And there are others. And there are others in other fields as well. And that's the kind of direction and attention we need if we're going to make the systems level changes to truly embed culturally responsive healthcare into our healthcare systems. We'll go to the next slide. So when I think about culturally responsive healthcare, one of the things that really jumps out for me is the need to take intersectional identities into consideration. And when we look at the intersections of our lives and pay attention to those intersections, that's how we get to culturally responsive healthcare. When we pay attention to those intersections and how those intersections work with the people that we're working with. So looking at issues of power and privilege, looking at the compounding structural barriers, looking at ways in which we can use the privilege to mitigate the harm caused by the oppression and the marginalization. So, for example, sometimes we talk about Black Canadians as though we were all the same, as we were monolithic. But gender matters. Black women's experiences are different than Black men's. Sexual orientation and gender identity matters. Black trans women experience so much transphobia, racism, homophobia. Unbelievable. The intersection of class, ability, persons with disabilities who are also racialized have additional barriers that they have to overcome. So when we're talking about culturally responsive healthcare, we need to pay attention to intersectionality. We'll go to the next slide, please. But that intersectionality can also help us to determine where we interject change. So when you think about the levels in which change can exist, I use these 4 Ps. These 4 Ps are critical. So the personal is important, but so is the professional, so is the political, and the policy. And we all contribute to the change agenda. And we contribute to the change agenda on all of these levels. We'll go to the next slide, please. So when I think about creating change in healthcare, and I think about the work that's been done in different parts of the country, I think about our research project, the Racism, Violence, and Health study, I would say that work has been leading change, and it's leading change through critical reflection. So reflecting on what's happening, why is it happening, who's making the decisions, who's at the table, and more importantly, who's missing, who's not at the table, whose voices are not amplified, and how can we bring those voices in to our spaces. And through it all, I would say that one of the strategies that's very impactful is positive disruption. So disrupting the status quo. Disrupting the status quo in a way that people pause and listen and not shut down because they feel they've been attacked. So engaging, bringing people in, calling people in as opposed to calling people out. But doing that work will lead to the kinds of changes we want to see in our country. We'll go to the next slide, please. So, wrapping up, when I think about culturally responsive healthcare, one of the things that's important is acknowledging that anti-Black racism is a problem, and then working towards transforming the system. So it's not enough to sort of create the awareness, do the analysis, then we need the action, and we also need to hold people and hold systems accountable. When we're trying to get to a space of culturally responsive healthcare, those who've been on the margins, who are on the margins, should always be centered in the work, centered in policy development, centered in the implementation of the policy. When I think about your topic and redesigning healthcare, having patients and clients and communities, marginalized voices included in the redesign of healthcare is imperative. You can't do the redesign without including those who are most negatively impacted by the lack of culturally responsive healthcare. We'll go to the next slide, please. This requires a lot of bravery. Sometimes people talk about needing safe spaces. I like to use the term braver spaces because for many of us, there's no guarantee of safety, even in quote unquote safe spaces. It takes a lot of courage to address racism. It takes a lot of courage to address anti-Black racism. It takes a lot of courage to engage in that critical reflection. It takes a lot of courage to be a positive disruptor. And that courage is possible when we create braver spaces for people to operate from within. We'll go to the next slide, please. I want to quote here from Dryden and Norum in their article, Time to Dismantle Systemic Anti-Black Racism in Medicine in Canada. It's a wonderful article. The reference is there. This is an example of creating braver spaces. We can do this by listening to the voices of Black Canadians, patients, and healthcare professionals who've been grappling with anti-Black racism for generations, and by engaging with the many communities that have made recommendations for meaningful change to address the problem. So the deep listening, the willingness to hear the impact of anti-Black racism in health and healthcare, and the willingness to move forward. That's creating braver spaces. We'll go to the next slide, please. So to wrap up, and as you continue your day and the work in this summit, and then post-summit, I want you to be mindful of the fact that we all have a role to play. So when I think about culturally responsive healthcare and making it, how we make it a reality for all Canadians, it's an individual responsibility to make the shifts, but there's also a collective responsibility to make the shifts. We need to address it on the individual, cultural, and systemic levels if we want to truly make culturally responsive healthcare a reality for all Canadians. I wish you well as you continue your summit on this very important topic. Thank you.
Thank you so much, Senator Bernard. That was an amazing way to start our discussions on this topic for the day today. So I appreciate how busy you are and really, really appreciate you taking the time for us today. Thank you.
Thank you. I'm happy to support your advocacy work because it helps with, as I said, we all have a role. Thank you.
Thank you so much, Senator Bernard. On behalf of all of us here in the room in Toronto, your calls to action on centering marginalized voices and creating the braver spaces that are needed, they're potent antidotes to anti-Black racism and to enabling culturally responsive healthcare. Yesterday, we heard about the power and the impact of co-designing, of centering marginalized voices, of creating those braver spaces with the Métis community in Manitoba, Métis community members, and the impact, the incredibly positive impact on health and on access to health care that co-design, that centering, and that creation of brave spaces was enabled. We learned about how a patient advocate took her challenges as a South Asian woman, brand new to Canada, going through an incredibly difficult diagnosis and then surviving a rare blood cancer, and turning her experiences into a new organization, addressing the issues and the gaps that she experienced, including dealing with cultural stigma and the needed culturally relevant peer support that she was unable to find for herself. We heard about the vitality of Indigenous ways of knowing and being, guiding the work and how we work, including in planning, in service delivery, and in service providers. Indigenous midwives are the future. We heard a lot about changing narratives to align with facts, that our worldview shapes everything and human health is inextricably tied to planetary health, that it's not an opioid crisis, it's a toxic drug supply. Harm reduction and recovery are both part of the continuum of care for people who use drugs and not an either or binary. Housing isn't a privilege, It's a human right that saves lives, as well as a lot of money that's currently being spent on emergency rooms, prisons, and shelters. We need housing first to implement housing first, and with sustained effort, we can end homelessness, as they have been doing in Finland. There is so much creativity and partnership for supportive, deeply affordable, and Indigenous housing solutions. We just need to help them flourish. Today, we'll learn more about solutions to integrating social determinants of health within healthcare at the clinical bedside and culture as treatment. We'll hear about incredibly exciting initiatives that are taking place in a vital area where this summit community has been learning and successfully advocating for several years now, since our focus started back pre-pandemic on value-based healthcare, namely shareable or interoperable health information. We'll learn about race-based data, improving health outcomes, and community data governance. Without these direly needed data, I'll call them revolutions, but really it's been evolving for a long time and we're just need to get on the train. We're operating dangerously in the dark, including being unable to detect structural racism and really effectively address it and know how we're doing. So again, today we are encouraging everyone to write headlines. So on your tables, you should have a little stack of templates, newspaper headlines. You'll see the ones from yesterday up on the wall. And we just encourage you, as you're listening to all of the incredible content being shared today, to write a headline as if you were writing a news story. And we'll collect them on the breaks and we'll put them up on the wall. And then we encourage everyone to take a look and see what is everybody thinking and feeling as the day progresses and from yesterday. Also, for those of you online, please share on the whiteboard, and people here in the room will put it up on the wall. And they'll also take some photos of the wall to share with you online so you can see what people are saying. You might have to zoom in. Some people's handwriting is a little small and chicken scratchy, so do feel free to use big, bold printing for those who are online. Now, without further ado, I would love to welcome Antonella Scali, the Executive Director of Psoriasis Canada, to the podium.
Thank you, and I've invited our lovely panelists to join me to make their way up to the stage. So I'm really excited about this next panel to learn about social prescribing as an innovative way to address the marginalization that happens in our current healthcare systems. You ladies are welcome to come and join me up here. Kind of took our whole table almost. Yeah, so this is not a new concept, but I'm very thrilled to see it picking up momentum here in Canada, globally, as a way to, again, address the whole person. We've heard stories so far where people are not being served in the current healthcare systems in terms of everything that they need to be well, let alone actually getting the care they need to address their health issues. So social prescribing and culturally appropriate care is something we're going to learn about through our panel today as an approach that can help to address some of these difficulties and challenges that we continue to see. So I'm thrilled to introduce our speakers. Their full bios are on our website, so please check those out at your convenience. But we have Srija Biswas, who's a project manager at the Canadian Institute for Social Prescribing, where she's been working since 2022, supporting various national level social prescribing initiatives. And with her, we have Natasha Vaudin, who's worked in the community health sector for over 20 years and is currently the social prescribing project lead at the Alliance for Healthier Communities. And last but certainly not least, we have Dakota Recollet, who's the Director of Indigenous Cultural Safety at the Indigenous Primary Healthcare Council, where she supports training for individuals working within the healthcare system to learn the importance of adopting culturally safe and appropriate practices to ensure the best possible care for Indigenous people. So I'm really excited you're all here. And yes, I think your slides should be coming up, and take it away.
Thank you, Antonella, for that wonderful introduction. And hi, everybody. Good morning. Is this a Wednesday today? I have no idea. I feel like November is like a month. We don't know what day it is, what time it is. Like the days are so short. Like by the time you finish work, it's like night. So, well, good morning. So as Antonia mentioned, I'm Srija. I'm the project manager at the Canadian Institute for Social Prescribing. Is this what I use to change my slides? Just gonna check how this works. Oops. Oh, there you go. So I just wanted to share a little bit about, as Antonella mentioned, how social prescribing can act as a way to create a bit more patient-centered care. So I like asking this question a lot. What is well-being to you? Ideally, I would have used like a Mentimeter or something, but we have a really wonderful room here. So maybe some of you can shout out, what's well-being mean to you? When you think about well-being, what's the first word that comes to your mind? Yeah. Yeah. Absolutely. Yeah, absolutely. Stability. Beautiful. And it's interesting because the words that we're hearing, a lot of it are not really biological or clinical. They're all sort of like social factors. And that's also what we see when we look at statistics. So what we see in stats is that a lot of our health comes from the social determinants of health, like you mentioned, nature, feeling safe, feeling included, social connections, having access to good food and housing. And a very small of it comes from clinical or like biological determinants of health. But when we talk about healthcare or health system, this is something that we don't always think about as a first way to go, and that's the gap that social prescribing aims to fill. It bridges the gap between the clinical and the non-clinical sector of health. So what is social prescribing? Simply put, it's like I mentioned, it's the bridging of our traditional clinical care system with the social and community supports necessary for well-being. And it's a way to connect the formal healthcare system and non-medical supports with the goal of addressing social and structural determinants of health. While connecting social and clinical health is not a new concept for all of you, social prescribing is an umbrella term we use for these sort of approaches because it provides a common lexicon and a common framework to make it a bit more formalized and more systemized, so it's easier and seamless for it to be implemented and practiced. And social prescribing is a principle-based approach. While it does have a definition, and the definition you see here is an implementation definition that we have come up with our international and national partners who are doing this sort of work. But social prescribing is also a social movement, and we are using this to build power towards integrated care. And as I mentioned earlier, approaches like social prescribing is not new as a concept. You're most likely doing this sort of thing in your own practice already. But social prescribing, what it can do at its fullest is provide like an intentional collaboration opportunity between the clinical practices or physicians or the primary care or healthcare in general and the community organizations and the patient or the clients. And what it does is it prioritizes and enables a person's ability to determine their own goal and take control of their own well-being in a supported pathway by asking what matters to you, and then co-creating a solution with that participant that is meaningful for that participant. And that leads to shifting power from the healthcare to the resources in the community and facilitating people and communities to take leadership of their own health and of their own well-being. So this is just a pathway that we often see when we talk about social prescribing. Social prescribing in implementation can look different in different contexts, but this is usually what we see as a frequently used pathway. So the pathway always begins with an individual or a family member who's experiencing some sort of non-medical challenges that are affecting their health and who might be disconnected from the healthcare system or the system in general, but also also have unique goals and unique strengths and gifts to offer. And their interaction with the healthcare system, like a primary care visit, then becomes the doorway for someone to be identified with that non-clinical need that is affecting their well-being. So although generally an individual with a non-clinical need can be identified as a primary care practice, it doesn't have to start with a primary care provider. It could be a secondary care provider. It could also be a community-based organization, community health organization, or even it could be a family member or a friend or just a social circle where someone identifies that this individual is going through some sort of social needs and that is affecting their well-being and can kind of benefit from additional support. So once someone is identified with a social need, then the next step is referring them to a community connector or a navigator or a link worker. And this link worker plays a really big role in this social prescribing pathway because they provide personalized point of contact. They use active listening to sit with that person, to understand their needs, and then identify what matters to them, what are some of the things that they find value in, and they provide and then they come up with a prescription that reflects all those interests. They also provide supported participation, so they don't just come up with sort of prescriptions for the person to go on off themselves and find these interventions, but rather they kind of journey along with that individual to make sure that that patient is connecting to the programs that they identified they want to connect to. And they kind of make sure there are no barriers on the way. And also, the other thing that they do is they try to understand whether these programs are actually making an impact on that person's life. And they also empower people to take greater control over their own health. So when that individual leaves the social prescribing pathway, they're not left off on their own. They're connected to the society, they're connected to the community, they're connected to the system. So now they're more resilient and they're more able and confident to take care of their own health. So another important piece of social prescribing is, like I mentioned, there's opportunities for us to track the outcomes that comes out of these social interventions. So oftentimes the link worker will do this, and in a really good social prescribing setting, these outcomes are then sent back to the point of entry, whether that was the primary care provider or secondary care provider. So it creates like a really full picture of what that person's journey has been and what that person's health outcomes has been. And we have very promising results on the impact of social prescribing on systems level, on community level, and specifically on individual level. What we see in research is social prescribing has a huge impact on physical, on psychological, welfare, spiritual, and social aspects of well-being. And from multiple pilot projects across Canada, we saw great results. For example, we saw a 49% decrease in self-reported sense of loneliness and 12% improvement in mental health over a 1-year period for those who have attended social prescribing. We also see really positive impact on some of those hard to measure but really important factors that contributes to health. For example, sense of belongingness to the community, ability to manage your own health, or self-confidence. And when it comes to healthcare system, we also saw improvements in the experience of healthcare providers, and that it reduced clinical appointments for issues that can be addressed by community and doesn't require a clinical visit. So this is just a snapshot of social prescribing initiatives across Canada, and 8 provinces are right now leading this sort of work with diverse groups, inclusive of older adults, young people, caregivers, equity-deserving population, which we will hear a bit more about from our other panelists. While there are commonalities in the pathway and the core components of how social prescribing is implemented across different regions, there are also uniqueness to make sure that the social prescribing pathway is reflective of the infrastructure of that specific province. So for example, in some provinces, healthcare is taking a bit more leadership on social prescribing. In some other provinces, communities are leading a lot of this work. And in some provinces, health authorities are picking up on this traction and leading a lot of this work. And social prescribing initiatives in Canada did start quite some time ago, and it continued on provincial level. While there were tractions, conversations were happening more locally, which led to a bit of silo. And we recognize that there are learnings from one province that other province can tap into and really build into their own journey. And that led to a need for a convener who can bring together all these conversations and kind of give a space where we can come together and learn from each other. And this is what led to the establishment of the Canadian Institute for Social Prescribing. While situated within the Canadian Red Cross, Canadian Institute for Social Prescribing, or CIS, is a national hub to convene and support the growing social prescribing movement in Canada. So, and this support happens in a few different ways. So at CIS, we convene and collaborate with an intersectoral network of partners, and we use a co-design model to work together to develop new practices, to share insights, and build a unified understanding for social prescribing. And when it comes to knowledge, we raise awareness and mobilize knowledge by creating educational tools, training opportunities, events, and resources that can support the spread and scaling of social prescribing across Canada. CIS also strengthens the evidence base for social prescribing through research and evaluation, highlighting the impact of a national and global initiative. And last but not least, policy. We drive practice and policy change by sharing evidence with government and system stakeholders, paving the way for social prescribing and community health investments. So before I wrap up, I wanted to share a few new developments that we have at CISP, and I think can help folks in this room feel more equipped to think about social prescribing moving forward. So first of all, this is an evidence and gap map that we put together in last 2 years, and that gap map has a snapshot of a lot of different sort of interventions that are social prescribing or social prescribing happening across Canada and internationally. So it's a great tool to look at how evidence-informed social prescribing is and how other people are doing social prescribing. As I mentioned, link worker plays a big role in social prescribing pathways. So we did put together a link worker competency framework, and this outlines the domains, the competencies, essential skills, and knowledge required for link workers and roles that are similar to link workers, including community connectors, resource coordinators, or sometimes even case managers. And this framework is really to make sure the broader social prescribing workforce is well equipped to consistently deliver high quality care and support across Canada. Oops, sorry. And this is the economic impact report that we pulled together in last 1 year. So this is an in-depth analytical assessment of specific social and economic impact social prescribing can drive in Canada, and to understand the overall return on investment from social prescribing. And we have some key numbers here on the slide, but the finding basically demonstrates that social prescribing can play a huge role in addressing social determinants of health, reducing healthcare costs, and improving quality of life across diverse population. And this report can really inform in fund development and in advocacy with different sectors and building partnerships and getting buy-ins. So that's pretty much all from me. Before I wrap up, I would like to leave you with this thought that social prescribing is more than just a program. This is a movement to reimagine how we care for individuals and communities, and it's a movement to continue to advocate for a system that places individuals, the patients, and their well-being at the heart of it. So thank you. That's all from me. I'll pass it over to Natasha, who will do a bit of a deeper dive for Ontario, all the wonderful things that they're doing.
Hi, everyone. I have to bring the mic up so high because I'm so much taller. No, just kidding. Hello, my name is Natasha Bode, and I'm the lead for social prescribing at the Alliance for Healthier Communities. And I just wondered, so everyone here is a patient advocate? Is that kind of your role? Most people? Mix? Who are the other kinds of people that are here? is there and healthcare providers? Okay, 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 amazing. And are people from across Canada? Yeah, okay. So I'll just tell you a little bit about the Alliance for Healthier Communities. Well, I'll tell you a little bit about myself. So my background is health promotion, and I worked as a health promoter for many years at a downtown community health center in Ottawa. And I've been with the Alliance for 2.5 years. And for those of you who don't know, the Alliance is a member organization. We have 115 members across Ontario, and all of our members are community-governed, comprehensive primary healthcare organizations, and so that's community health centers, nurse practitioner-led clinics, Indigenous-led primary healthcare, with our sister organization, the Indigenous Primary Healthcare Council, and community family health teams. And all of our member organizations share a commitment to advancing health equity through the delivery of comprehensive primary healthcare. They serve populations systemically marginalized and underserved by other parts of the health system, and those who face the greatest barriers to health and the poorest health outcomes. So all of our member organizations are team-based and typically deliver a range of clinical, allied health, health promotion, and social and community support services. Let's see if I can work the clicker. Nope, I can't. No, I believe in myself. I can do this. I know. Sarija, what do I press? The green one, okay. Green one. Okay, I did it. Hooray. So all of the work at the Alliance for Healthier Communities is guided by our model of health and well-being. So when we do social prescribing work, it's guided by these principles. So it's rooted in health equity with a focus on, we use community development. It's an anti-oppressive approach. So this kind of model grounds all of our work, and then I'm sharing the holistic model of health and well-being, but I don't want to steal Dakota's thunder too much, so I won't spend too much time on that. But this is what guides our work in social prescribing and all of the work that we do. And then this is the same slide that Sri just shared, but just also wanted to say, like, our clinical health, that is only one portion of what makes us healthy. So I'll tell you a little bit about our social prescribing journey at the Alliance. So we started in 2018 with a pilot project where we worked with 11 different centers across Ontario, and it was a mix of urban, rural, francophone, different centers, and we tried out this social prescribing in a more formalized way, and we had mentors from the UK, and social prescribing looked different in every setting because each community is different. But we had a lot of great success with that project. And then in 2021, we started Links to Wellbeing, which is a partnership with the Older Adult Centers Association of Ontario. And what we're trying to do with that project, one of our goals is to have a seamless referral from healthcare settings into community settings. So in particular with the seniors active living centers across Ontario. So at the moment, we have over 200 healthcare organizations partnered and over 90 seniors active living centers in this project. And we completed 3 years and we're continuing. And then in 2022, we started Black-focused social prescribing. So looking at a way that we can make social prescribing culturally affirming. And this social prescribing is grounded in Black and Afrocentric values and principles with a focus on supporting families and children. And so how can we make sure that it's culturally safe? And so we're currently working with 4 sites across Ontario, but expanding to 10 next year. And then our fourth project is Social Prescribing for Better Mental Health, which was funded by the Public Health Agency of Canada. And with this project, we worked with 28 sites to improve social prescribing pathways. We developed resources and tools, and we also did regular quality improvement healthcare coaching with each of the sites to help them implement and then make their social prescribing really sustainable. And I'll just share, these were the goals from our social prescribing for better mental health. So just to go in a little bit of a deeper dive into a couple of our projects. So to train service providers to implement social prescribing with a health equity lens. So we had those focused monthly coaching sessions. We worked with 284 different providers across Ontario The second objective was to identify individuals at risk of poor mental health. So using our electronic medical records, screening tools to do assessments, including around loneliness and well-being over time. And the third objective was to navigate individuals to the most appropriate services. So we worked alongside 211 Community Connection to deliver closed-loop referral pathway, and then each center kind of found the best internal and external referrals. And then we used that co-design that Srija was talking about and engaged, evaluated, and shared impacts and lessons learned. So I'll just share a little map of Ontario. I should have had a whole map of Ontario just in case there's people from, there's probably people here from other provinces, but these were where our 20 sites were located across Ontario. So this included 4 Francophone centers, 2 Indigenous-led primary healthcare organizations, 4 family health teams, 2 nurse practitioner-led clinics, and then we did an additional spread and scale after that project to work with 13 additional sites. So you can kind of see we were spread out across the province. And then just a brief overview of some of the results from our projects. So we can see how the impact of social prescribing continues to grow. So in 2018, we were able to see through the pilot project how social prescribing improves well-being, decreases feelings of loneliness, and these effects continue to scale up. And so the other piece when you're looking at health equity is it's not just telling someone, oh, you know what would really benefit you? I'm hearing you're lonely, like you should go to the senior center, but okay, you don't have money to take the bus, you need bus tickets. Okay, you also might need an interpreter because you don't speak English or French. You prefer to access a virtual program. Let us help you access a tablet and then help you get subsidized internet so that you can access these things. So it's really removing all the barriers of access so that people can participate fully. And then in links to well-being, we found that the warm transfer of the client from the provider. So people, as I think most people are aware, there's lots of reasons why people mistrust systems like healthcare. And so with links to well-being, we found one of the most important things was they became very trusting of the staff at the health center. And then we started talking about this senior center as another place where you could go to connect. And that can be like a big leap for people who have limited contact, are used to maybe being very cooped up alone in their apartment, even though they kind of know that there might be some benefits. So having that trusted healthcare worker, the link worker or the health promoter walk them over even, or we have a link worker who drives the clients to the senior center and takes them on a tour the first time to kind of help build those transitions over. And then with social prescribing for better mental health, we saw how deepening and expanding community relationships and using asset-based community development model was important. So making sure we look at what is not what's wrong in the community, but what's strong in the community. And you often don't have to, I've presented at with clinicians or physicians, and they're like, well, I don't have the resources to build a whole social prescribing program and find all these, programs in the community. But sometimes it's as simple as, we'll talk to clients and they say, I used to go to church, 15 years ago. Oh, is that something you could consider doing again? Or I always used to have dogs growing up. Oh, could you, a lot of them are not expensive or complicated. It's just having that conversation with your client and figuring out what matters to them and how to help kind of connect them. It's almost like any kind of goal setting that you do as a health promoter, just helping someone kind of connect with what's important to them and then removing the barriers to make it possible, as much as it is possible. And then just a little snapshot, our Black focused social prescribing, we'll have the final report in January, but here are a few preliminary results from our evaluation. So the most common prescriptions across all 4 sites was food security, and it's probably one of the most common prescriptions across all of our programs. So it's no surprise we're dealing with a cost of living crisis. People are really struggling. The most common prescriptions were food security. The second one was Black focused community events. So we have things like hair drop-ins, dance and drumming circles, barbecues, all kinds of fun events that are culturally affirming. Number 3 was arts activities. Number 4 was connections to other programs and services. Number 5 was physical activity. And number 6 was social programs. And what we found was 88% of clients who responded to the survey were worried about running out of food before they had money to buy more, often or sometimes. And 40% of the survey respondents reported not being able to afford balanced meals often and sometimes. And 87% of the survey respondents agreed that Black-focused social prescribing made food available to them. And then I'll just show a few pictures. So we did a lot of learning events. So this is, we had a capstone event at the end of our social prescribing for better mental health where people, the staff who were involved could share what they learned and share knowledge. We also have a community of practice for social prescribing in Ontario, and so sometimes we have in-person meetings, though they're mostly virtual. So overall, we had about 3,000 people attend our events last year. And I'll just share, created 5 videos that are profiling social prescribing work across the province in different settings. So here we have an image from Seaway Valley at their community garden in Cornwall, Ontario, and another image from Regent Park Community Health Centre in Toronto. They do an art program at the AGO. So those are 2 of the videos out of our series, and you can feel free to use the QR code, or I'm happy to give you the YouTube address. I don't really know what technology people are using, but I'm trying to stay hip and with it. So this is an image from Taibu Community Health Center in Scarborough, and we also have videos about Centre de Santé Communautaire Hamilton Niagara and Lakeshore Community Nurse Practitioner-led clinic. So check those out. They're all less than 5 minutes, but they really tell the story of how social prescribing can work in different settings. And we also worked along with CISP with the Center for Effective Practice to create a clinical tool for clinicians to use who want to implement social prescribing. So that's a free tool that's accessible to everyone if you want to check that out. And if you're interested, if this is piquing your interest, there's lots of ways to get involved. So as I mentioned, we have an Ontario social prescribing community of practice. Welcome to everyone who's interested. There's a national social prescribing community of practice facilitated by CISP. And we also have created these health equity focused social prescribing online learning modules. They're free modules, also accessible to anyone who's interested. And we go through different aspects of social prescribing. So everything from building your interdisciplinary team, how to build an asset map of what's in your community, how to work with volunteers, how to meet with clients, how to wrangle that data that you're collecting, how to use your electronic medical records, all of those pieces. And you can kind of go through the learning at your own pace and in whatever order you prefer. And we have just added our 10th module, which is the clinicians module, and then we will have these learning modules will be available in French in March. So we'll have it in both official languages. And we have some final reports, and I did bring some paper copies today if anyone's interested, but they're also available on our website. So if you're getting super fired up, super interested, we have final reports from Links to Wellbeing and Social Prescribing for Better Mental Health. And then we have this document called Link Workers Work, and it's a document that we use to advocate for funding for link workers across Ontario, just showing how they can sort of save costs and improve healthcare. And then I think we're going to have like a little fireside chat or a little chat afterwards where we can go into some of the stories that kind of paint the picture of how social prescribing is working. So that's it for me. Thank you very much, and I'll pass it on. I'll pass it on to my esteemed colleague, Dakota. It's the green button. I'm very sophisticated.
All right. Sorry, guys, I'm a little bit short, and you might not see my head very well, but I do need to put my speaking notes up because I will ramble when it comes to cultural safety. So, yes, it's really important that I have these up here. Ani Bojo, Dakota Reklay, Indigenous Cause, Wanapate First Nation, and Donjaba. So my name's Dakota Reklay. I am from Wanapate First Nation with direct familial ties of Wikwemikong and Whitefish River on Manitoulin Island. I reside in Sudbury with my husband and my 5 children. I have experience working in 2 Aboriginal health access centers as well as health promotion in the community of Wikwemikong. I've been with the Indigenous Primary Healthcare Council now for almost 4 years, leading our Indigenous Cultural Safety Program. I tend to do long introductions and ground ourselves when we do this work. So thank you for joining today. Before I dive into the main topic on culture as healing, I just want to share a little bit about IPHCC just so you can get some better understanding and perspective of the work that we do. So the IPHCC is an Indigenous governed and Indigenous led organization, and we represent 24 Indigenous primary healthcare organizations throughout Ontario. The organizations provide essential healthcare services to First Nations, Inuit, and Métis people across Ontario, and our key mandate is to advance and evolve Indigenous primary healthcare services. So to achieve this, we work collaboratively, collectively, and deliberately to support the health and well-being of Indigenous peoples. So our beautiful model of holistic health and well-being up here, I don't think it, there we go, that Natasha shared as well. So at IPHCC, our member organizations provide integrated and holistic care to Indigenous peoples. And this care includes traditional healing practices and culture-based services under our model of holistic health and well-being. So by addressing the spiritual, mental, emotional, and physical aspects of health, we strive to support the complete well-being of the individuals that we serve. So this approach goes beyond the concept of physical health or simply the absence of disease. It is about nurturing the whole person and recognizing that true health involves balance across all dimensions of life. So our model is firmly rooted in a population's needs-based approach to healthcare planning, and we incorporate Indigenous-informed evaluation methods and scaling leading practices to achieve excellence in Indigenous health. So culture is central to this model, and culture as treatment and culture as healing is the core of everything that our organizations do. So the need for Indigenous cultural safety in healthcare, and this is just to set the context for a bit about what I'll be sharing on integrated and holistic health and culture as healing. So if individuals in this room are not aware of the history, I strongly encourage you guys to do some research and just kind of further educate yourself, because this is a very key component of understanding some of the unique needs of Indigenous people moving forward. So in order to understand those needs and in order to understand why they have the health outcomes that they do, it's really important to understand that historical context. So colonization forcibly displaced Indigenous peoples. It also dismantled traditional governance and enforced assimilation policies through things such as the Indian Act, residential schools, and the 60s Scoop. These were all designed to erase Indigenous cultures and identities. And colonial practices replaced Indigenous health systems with Western or Eurocentric models, which disregarded Indigenous ways of knowing and healing. And so this really did institutionalize racism within healthcare, and it made it difficult for Indigenous people to access culturally safe services. So the impacts of colonial practices such as residential schools, Indian hospitals, forced sterilizations, and birth alerts create some deep historical trauma, and experiences of neglect, discrimination, and racism in healthcare have led to significant mistrust, and it makes individuals reluctant to seek care, which is a really key component, because if they're not seeking care, then they're waiting, and that's where we see their health outcomes become much worse. So colonialism has resulted in notable health inequities for Indigenous people, such as lower life expectancy, higher infant mortality rates, increased rates of chronic conditions, and more prevalent mental health challenges and substance misuse, as well as limited access to prevention services. That's a really key point, especially when you consider remote communities and preventative care, very limited access to things such as pre-screening, health promotion, community care, all that sort of thing. So individuals often have to travel very far to access services, and by the time they reach that point, it does become critical. So Indigenous cultural safety is critical because it addresses the historical and ongoing impacts of colonialism, which have created systemic barriers and led to these disparities in health outcomes. So by fostering culturally safe environments, ICS can help build trust between providers and Indigenous communities, ensuring that care is respectful, inclusive, and responsive to the unique needs of the patients. So IPHCC's approach to advancing ICS, we do have a training program at IPHCC. It includes online training modules as well as customized virtual and in-person workshops and a variety of educational resources. So these are designed with a trauma-informed approach to support healthcare providers in understanding the historical and ongoing challenges faced by Indigenous people. Fostering culturally safe and competent care. Our work is done in collaboration with numerous partners across Ontario to ensure that ICS is effective and integrated into the healthcare system. And through these partnerships and our collective advocacy, we aim to create a healthcare environment that is not only culturally safe, but one that genuinely supports and uplifts Indigenous health and wellness. So we continuously advocate for sustainable resources to advance the health needs of Indigenous people, and our work is guided and strengthened through the collaborations with many health partners, health organizations, elders, knowledge keepers, and community members. So looking at social prescribing from an Indigenous perspective, or viewing it as culture as medicine. So as I mentioned early on, culture is at the core of everything that we do, and when we consider integrated health methods for Indigenous communities, I want you to kind of rethink social prescribing, even though that's something that we were heavily focused on today. So this is not a new concept to Indigenous communities, and for time immemorial, Indigenous people have fostered health and well-being through holistic practices that integrate care across physical, emotional, spiritual, and community dimensions. So this holistic health approach has always been central to Indigenous lives, long before the term social prescribing emerged in Western healthcare. So rather than viewing well-being through a deficit-based lens where individuals need a prescription to correct what's wrong, Indigenous perspectives focus on empowerment and cultural revitalization. So examples like land-based healing and traditional practices serve as powerful culturally rooted pathways to health. Land-based healing, where individuals engage with the land through ceremonies, harvesting, or just being outdoors, helps foster a deep connection to culture, land, and community, which is central to Indigenous well-being. So social prescribing in its true form is simply a recognition of what Indigenous communities have always been doing, and that's prioritizing the strengths of their people and nurturing cultural identity and taking an integrated approach to well-being. So the reason I highlight this is because while social prescribing is a great movement, and it's a very significant step in healthcare because we do have such a reactive healthcare system, and social prescribing is looking more at prevention and how do we put people's first and how do we take a person-centered approach. But it's important to rethink that concept slightly, especially if you're working with Indigenous communities or Indigenous clients, because language is a really crucial thing for Indigenous people, and the term prescription itself can have a very negative annotation to it. And for communities and Indigenous people specifically that already have such mistrust in healthcare system, it's really important to be mindful of that language. So while the concept is amazing, just especially being mindful of who you're working with is a very significant thing when it comes to Indigenous communities. So some recommendations for advancing Indigenous cultural safety in healthcare systems. So this is essential for transforming environments into spaces that are culturally safe and supportive for Indigenous people. So understanding Indigenous health within the context of social prescribing can play a significant role in driving this transformation. Emphasizing empowerment and cultural revitalization, mandatory ICS training for all healthcare staff ensures cultural safety becomes an organizational priority. And policies should embed ICS into onboarding as well as ongoing professional development, making it part of accreditation standards and healthcare excellence. So ICS must be viewed as a continuous learning journey, and it should drive meaningful outcomes, and it can't be seen as just a checkbox exercise. It must foster accountability and translate into real changes, such as improved care protocols and the removal of systemic barriers. So leadership should be allocating resources and prioritizing ICS initiatives to drive this change. And visible commitment from leaders, such as including this in strategic goals, it really does set the tone for entire organizations to view this as an ongoing thing. So healthcare systems should also actively engage Indigenous communities in program and policy design. And by actively engage, you hear the terms co-design and co-create and these things quite often. That piece is super significant. So it's important to engage Indigenous communities early on, not once the work has already started, because then you're coming to them with a project or a program or an initiative where you've already kind of set the tone for how that's going to look. And so if you're engaging early on and having those discussions early on, and not just including voices, but collaborating and partnering and, you know, the co-design and co-create terms that we hear so often. So transformative change in healthcare begins with leadership commitment. Leaders do need to champion ICS, allocate resources, and create these accountability mechanisms. So moving forward, how can we all contribute to this? So advocating for ICS training within your organization is a really crucial step. This can have positive impacts on healthcare outcomes, as well as patient trust and health equity. It's important to build genuine relationships and actively listen and engage. Self-reflection is also key to identifying and addressing biases, so it is important to acknowledge your own assumptions, to learn how to be uncomfortable with addressing these assumptions and to grow from that and embrace learning, as well as unlearning. So I highlight unlearning again because ICS and embedding Indigenous knowledge into education and healthcare systems is still fairly new. And so we have a lot of providers that have been out doing this work for quite some time. And a lot of this stuff wasn't stuff they were educated on going through their own educational journeys. And it's really difficult to unlearn something that you've been doing for so long. So that's why we say it's important to embrace learning, but also to really focus on unlearning and looking at, some call it decolonization. There's so many terms that get thrown around, but it's just learning to be a little bit uncomfortable with addressing some of those own biases that you may carry. So as a reflection to take away, just get everyone to think about some steps that you can take to foster cultural safety within your organization. And while I wish I had more time to go through ICS, because like I said, I could ramble on about it forever, but that concludes our presentation today. Thanks, everyone.
Is it working? It is. I was thinking we would take a few minutes just to sort of like have a conversation, the three of us, but also we can take some questions from the floor too. I think we have about 20 minutes left or so. We have 25 minutes, so it's time. Well, I'm going to invite Dakota to ramble on, as she's good at that. No, but I thought we could start just by the three of us sort of talking about some of our work and maybe sharing some stories, and then open it up to any questions. And so the first question I thought we could start off with is: there something you do to socially prescribe yourself? Is there something you do to support your own well-being?
Is it working? Okay, perfect. I think it was on and I just turned it off. So I love that question, Natasha. And so for me, I sing. I am trained in South Asian classical music. And I think for myself, I socially prescribe myself for singing whenever I'm feeling a little bit overwhelmed, or I feel like that life is kind of, has been a bit chaotic, or I just need some practice of mindfulness, or a bit like, just feeling a bit more peace. And I got this from my mom, actually. Growing up, I always used to see my mom, like, whenever her life would get a little bit overwhelming, she would take some time to herself and spend like half an hour just doing that. And I used to wonder, like, is there a reason why she does that? And over the time, as I kind of started to understand social prescribing, I realized that, she was actually so doing a social prescription on herself. She was just prescribing herself to something that it was close to her heart, that resonated with her identity, her what held values to her. And yeah, I think that's something that I also kind of like picked up from her, and I have been doing this for God knows how long. But I love this question. I can go on and on about it, but I should shut up. And Natasha, what about you?
One thing I do, I live in Ottawa, and so as soon as the cross-country ski pass for the Gatineau Park goes on sale at the discounted price, I get my ski pass. And for me, cross-country skiing in the Gatineau Park with my family or friends is something that's keeps me grounded. I'm out in nature. There's a social aspect. We usually eat cheese. Like it's just all around feels good. So that's something important to me.
Is it on? Okay, sorry. I'm not good with technology either. I have a very busy life with 5 kids. They play competitive sports, and my daughter dances. So it is difficult for us to find some time to take care of our own well-being, but our family does go hunting once a year. So that's something that we've come to really look forward to, and it kind of just shuts us down and disconnects from the real world, and we go out to our hunt camp or wherever we're going for a week, and that's kind of like just our refresh for the year. So aside from that there's not much I do with my work, and my kids are a very busy lifestyle, but we do definitely cherish some of our downtime. So
I can so relate. I feel like all I do is work and take care of my family and then try to throw in something for myself here or there. And just wondered if anyone had a story to share about maybe a patient journey or a patient experience with social prescribing.
Yeah, I can start. So we used at CIS, we had a participant advisory council, basically a group of people, older adults who has lived experience with social prescribing, who were participating in social prescribing. So I wanted to share a story from there. So one of my participant advisors, she was identified with dementia in her early 60s, and it, although she was an early onset, but it did have a huge impact on her day-to-day life. She didn't have access to her driver's license anymore. She needed someone to take care of her whenever she's going outside. She was not, she had some restrictions as to when she can go to the kitchen. So lots of changes, and her partner became kind of like a full-time caregiver. Although she didn't need a lot of caregiving, it was just a huge change in her life, and the way she phrases it is, it affected her sense of purpose. She started to kind of lose like the sense of who she is. And then she was talking to her healthcare provider who kind of identified that, oh, this person has a social need, and kind of introduced her to social prescribing. And she started social prescribing. In like couple of months span, she noticed a huge impact. She started joining those dementia support group programs, where she felt like there are other people who are also going through similar life situations, and that really helped her feel more connected, feel like she belongs somewhere in the society. And the other thing that she kept talking about is hope. She found hope in her life. She felt for a certain moment, she felt that her life was kind of, it's gonna just be this way, dependent. But that group, or joining social prescribing, really gave her hope that there's more to life. And just because I have something, it doesn't mean that everything else kind of the world is not closed off to me. And eventually, she was so inspired by social prescribing that she became a social prescribing advocate. She started her own dementia support group. She was leading a lot of social intervention sort of work. She was working as a participant advisor with us, and she also wrote a commentation piece with FAC, Public Health Agency of Canada, just sharing her story and how social prescribing made a huge impact in her life. So I love that story because it really it makes me feel motivated. It also helped me see how the work that we're doing, we talk about pathway, we talk about systems change, but these stories are really what holds a lot of value, because it makes us feel connected to the work that we're doing, and we can really see the impact on individuals' lives. So that's a story I wanted to share.
I think that really speaks to the intangible aspect of social prescribing, or like one of the greatest benefits, is when people are given purpose and meaning in their life, and an opportunity to give back can be so meaningful. Did you want to share a story, or should I go next? Okay, well, one that just came to mind while we were talking, I was fortunate enough to attend one of the focus groups for Black Focus Social Prescribing, and we did very arts-based participatory evaluation with community members, and someone shared a story. So living in the shelter, newly arrived to Canada, and she was talking about how she was coming up to a graduation date for a program she was attending. And she's like, but I didn't want to go because like my hair looked terrible, and I was actually not leaving my room because I just didn't feel good about myself. And she said, someone told me about these hair drop-ins they have. And so I thought, okay, it can't hurt to go. And she said, I went to the hair drop-in, and not only did the hairdresser know how to deal with black hair, I didn't have to explain anything. He knew about my culture and my home country. And she said, for the first time since I arrived in Canada, it felt like coming home. And so when people say, oh, it's a hair drop-in, what does that have to do with health? Like that sense of belonging that she experienced. And then, well, she shared this, and she said, then my hair looked good, and then I felt good about myself, and I was able to attend my graduation ceremony, and that was great. And then, as she talked more, she said, and then these navigators connected me. I hadn't seen a doctor since I came to Canada, so they were able to get me connected at the community health center, and I was able to talk just about some of my health concerns, and having like a Black navigator who understood the culture and who, like, that helps to build trust. And then the coolest thing happened in the focus group itself, because these were all community members who had been gathering and going to activities together. And so several women in the room were like, it got like really anti vibes happened, where they were like, where do you live? I am coming over and I will do your hair next week. And they started making those connections. And a lot of people said, oh, these were just women I would see at community events. And then because of the Black Focus Social Prescribing, now we're a community. We know each other. We're a village. We take care of each other. We can look out for each other. So that's another one of those. It's hard to measure, but like knowing people and trusting people in your community is such a great determinant of health and such a protective factor.
I can share, but it's not necessarily like a patient story. It's just looking at more of some of the successes of what we're doing with our Indigenous healthcare organizations. So talking about that integrated care approach, there actually is an Aboriginal Health Access Centre in Sudbury, and many of them across Ontario do this, but just looking at the successes of that integrated care. So this health centre has an alternative school as well within the health centre itself. So those students are actually like 12 and under, like they're young students, and they don't fit within the normal or systems of education, which is really crucial, because there's all these systems and there's so many barriers, not just within health, but health is a big part of that. And so these students have access to community programs. They have access to equine therapy they go to quite frequently with some of the workers at the health center. And my son actually attended that school for a while. So those are just some success stories of how some of our people can be connected to their culture within these healthcare organizations. And that's crucial, because as I mentioned in my presentation, they didn't have access to it for so long. And actually policies within the Indian Act and other areas actually banned a lot of these ceremonial practices. So it's not just about reclaiming their culture, but it's about finding that connection that they didn't have for so long. So that's a big part of their health. And it just shows the integration that some of our organizations are doing are actually beyond health, like they're incorporating other systems into it. And so the alternative school is a really good example, because those youth that struggle in mainstream education have a holistic approach to education and health all in one. So it's a pretty great story, success story for one of our organizations anyways.
I don't know if you have any stories from the clinician or provider or staff perspective, or should I say one?
You should say one.
Okay, I'll say one. I guess just from what I've heard from providers and so at first, when we started at my community health center with this social prescribing, there was a bit of skepticism, okay, what's a yoga class going to do for my patient, or how is this going to impact? But then So we used our electronic medical records and we pulled out clients who were frequent users of primary care and who also had NCODES, which is like your issue addressed around low-level anxiety, low-level depression, or loneliness or isolation. And we kind of focused on those folks. And so those were the clients that were coming to their doctor frequently and saying, since my wife passed away, I'm just lonely and I don't quite know what to do with myself, or some of those concerns that are very hard to address clinically. They would get referred to social prescribing, and the link worker, which in our case was a health promoter, would sit with them and say, okay, I didn't call them and say, you have been referred for social prescribing because you're very lonely. Like, it wasn't like that. It was like, your doctor thought that you might benefit from some of these programs we have to offer, and I'm going to talk to you about some of the programs, and just tell me if any of them resonate with you. And it became a conversation. And then what we heard from the clinicians was like, wow, that client came for her checkup and her anxiety was greatly diminished, and we were able to get through the checkup appointment much more smoothly because she attended this stress reduction group, but she's also in this peer support group. So some of those like non-clinical needs can be met through other ways, and then that also helps with our clinicians to have for them to be able to focus on what they do best, which is the clinical side. So it's not really a story, but sort of a story. Okay, so maybe at this time we could open it up if there's any questions from the audience. Oh, there's a lineup. This is exciting.
We also have perhaps online questions. We'll find out.
Oh, we're online too.
We do. Okay.
I start. I have an ask as well as a question. Maybe I start with my ask. Dakota, you talked about a strength-based language, which I think is really important. It's something I believe in. My background is in advocacy around drug policy and the toxic drug crisis. And one thing we advocate is person-first language. And Dakota, if you don't mind me pointing out, you used the word, when you were describing, you said substance misuse. And what we encourage people to do is to say just substance use. We don't say mental illness anymore, we say mental health. And when we say mental health concern, we know there's something going on with the mental health. So if for all of us here as health providers, if you use person-first language, avoiding the words like addict and such, it's a person who uses substance use. Sometimes you can say problematic substance use if you want to be more prescriptive. So sorry for picking on you, but that was such a good example. And the question I have with the link workers, if you have people with lived experience, like are they health professionals? You have people with lived experience, and also for Dakota, question, if you maybe have examples of Indigenous people being embedded in healthcare somewhere, in a hospital, making people feel more comfortable, feeling connected. So that's my question. Thank you. Question.
So we did a lot of work with CISP about coming up with those link worker credentials. And so what we see as the most important qualities for a link worker to have is someone who can build trust and rapport with members of their community, someone who knows the assets of their community, and those are more important than any type of healthcare qualifications, in my opinion. So with the Black Focus Social Prescribing, our navigators are members of the community. They know which referrals are going to be culturally affirming for the clients they work with, and they can build trust, and they're trusted people to their clients. So for example, when we work with Black Creek Community Health Center is one of our centers, and they said we would never refer to the Black Creek Historic Pioneer Village because they erase Black people out of the history of Ontario. So that would not be a culturally affirming referral, for example.
And to quickly answer your question about embedding Indigenous healthcare workers into the systems, we do have quite a bit throughout Ontario, and it's still a lot more to do though. There's a lot of barriers that present themselves with that as well, but we do have Indigenous patient navigators throughout various hospitals. I could give like examples, but that would go on. And some hospitals actually have started making, they kind of call them like ceremonial rooms. When you consider like religious spaces in the hospital, we have some hospitals that are incorporating those as well. But there is still a lot of work to do. And we still continuously face kind of challenges because embedding Indigenous health into mainstream healthcare organizations presents its own challenges. But we do have navigators and other supports throughout various organizations that can help make sure that there's access and there's integration and that clients are aware of the resources that are available.
Thank you so much. It's so wonderful to hear about the incredible flourishing of culturist treatment and social prescribing across Ontario and the country. I just want to acknowledge that online and in the room today, there are many patient groups who maybe after hearing this presentation realize that they are providing sort of social prescribing spaces. There's a lot of peer support that is offered by and other types of probably social prescribing initiatives that are offered by patient groups. And but I think probably many struggle to get that connection made at the point of primary care. And so I'm wondering if there's the opportunity for any interested patient groups to send people, perhaps many of them have medical connections, medical advisory boards, but to send people to the communities of practice to start to learn more and see if they can find opportunities to create that better integration, because I think that's probably where a lot of the struggle is. And I wonder if you have any experience or expertise or tips and tricks to offer when looking at those fee-for-service models, of primary care, because I think, a lot of these patient groups are national, and so there's, we don't have necessarily as much team-based care in, across the country. So has there been any learning in terms of, facilitating those solo practitioner physicians, family physicians, in being able to socially prescribe?
So I have been speaking at a lot of clinical settings in the past couple of years, and so with solo docs or smaller teams, I always say, like, start where you can, start small. So there's lots of really accessible referrals. It could be a referral to 211. It could be a referral to the Ontario Caregivers Organization, or a referral to the the Older Adult Centers Association of Ontario to get connected with a senior center. Like, that can be the sort of link worker for someone who's not in a team-based setting. When it comes to fee-for-service, I don't have the solution for some of the challenges facing our healthcare system. I think maybe Dr. Jane Philpott might be the person who might be fixing it right now. But what we do see in Ontario is there is a move. Like the Ontario government seems to be seeing that the team-based approach is working, and there's been funding put towards that. I'm also working with a really interesting team in like a community resource center that offers counseling, has partnered with their medical clinic in a rural area outside of Ottawa, and so they are sending their one of their counselors to the medical clinic one day a week to help do some of the social prescribing. So I think it's also those kind of innovative partnerships. It's a clinic with physicians and a receptionist, and there's no other team, but they've partnered with another organization that does not have a waiting list for counseling. And so the physicians were seeing, mental health is a big concern of our patients. We don't know where to send them. So that's like an example of a really innovative partnership that is that's doing really well. I don't know if that answers your question.
Do we want to go online next, or? Okay, thank you. Thank you all, fantastic presentations. Wonderful to hear about this and more concrete examples of how health is so much more than the absence of disease. So I'm a professional data geek. So my question, I have a very simple question for Natasha, but warning, if your answer is yes, I might have like 206 follow-up questions. So for your...
I'm here all day.
Okay. Actually, I live in Ottawa as well, so that could be a problem. Actually, I'm in Gatineau Park a lot too. For your 28 sites that were involved in the social prescribing, are any of those details being recorded in the patient record in their EMRs? Yeah. Uh-oh.
So that's not a complicated question for me. Like, the advantage to being a member organization of the Alliance is that we use the same EMR and we're able to pull information. And so we like, part of our project, we created templates that can be used in EMR, and that's how we can track it, and that's how we can pull information. And I'm happy to share those and even we've been able to use them with other EMRs. So they're like, we use PSS is one of our main EMRs, but I've been able to share the forms, and they've been used in other EMRs as well, so I'm happy to share that. Yeah, and we started with the Better Mental Health. We made it, we had it sort of 25 questions you asked your clients every time you met with them, and that gave us a lot of information. And then what we heard from our staff was like, this is too much. So we have it's more simplified and streamlined now, but we can still pull the information. And the other thing that we do, that Alliance members do, is we ask, every time every client we work with, we get their socio-demographic information, and that's how we know, most of our clients are living in poverty or whatnot.
Wonderful, thank you. I'll be in touch.
Did you want to go ahead? I'll do the couple from online first. So I just have two from the online community. The first one is, we know that Canada is going through a primary care crisis right now, and many Canadians don't have access to a family physician. So how do those who do not have a family doctor access social prescribing?
I can share some of the innovative ways folks are doing this. So I am heading a caregiver-focused social prescribing project. A lot of the time what we're hearing is people go to caregiver organizations because they heard about it, and then they go talk about how they don't have a primary care provider. So, and then the caregiver organizations then connect them with the primary care provider. So that's a reverse way of like, so how social prescribing, it doesn't have to start from primary care provider, but rather it could start from an community-based organization and then get them connected to a healthcare provider. So that's something that I'm hearing from a lot of provinces. Natasha, do you have any stories from Ontario?
I mean, it's really important for everyone to be connected to primary health care. That is the person who knows your story. And like, when I see my kid's doctor, they've known that is so important. And I think that we can't minimize the importance of that. What I can speak to is sometimes social prescribing can support with the waiting lists. So for example, at my community health center where I worked, there was long waiting lists for counseling. But in the meantime, so maybe you had to wait 6 months to see a counselor, for example. But in the meantime, we had a group called Overcoming Anxiety and Depression, which was a peer group where people could share their successful strategies. So while you were on the wait list, there was other services or programs that were maybe more cost effective than like meeting one-on-one with a mental health specialist that could still support you. And so people would join those groups, but they would also have access to social prescribing programs like creative writing drop-in or stress reduction program, or some of those things that also support your mental health. And what we found with some of those peer support groups were, often what people are feeling is like, I'm the only one struggling. I'm the only one living alone downtown in an apartment, feeling isolated. And then you come to some of these peer groups. So, I mean, that's one solution, is for some of these long waiting lists or lack of access, there's other ways to kind of support people. I don't have the solution to the healthcare problems, but we're working on it. Like, all of these things together, I think, can kind of help build a better healthcare system.
Okay, great, thank you. And the other one was, the way that social prescribing has been described reminds me of patient navigation. Can you please share what some of the distinctions or similarities between patient navigation and social prescribing are? I
I mean, I I feel, so just my personal belief, I feel like we need patient navigators because the healthcare system is so complicated to navigate. Like, if only the healthcare system was a little more easy to find your way. So for me, when I think of, generally navigation is to help people get connected with those services, and the link worker role is more just to ask people what matters to you and what's important to you, and really looking at that sense of belonging and inclusion, as well as anything like the arts or nature or social connection, all of those things, physical activity, food security, all of those things we talked about. So I'm not really sure. I think there's overlap between the two. I don't know.
And I think, Tashi, you have covered everything, but just wanted to add that the other uniqueness of a link worker is they want to tap into the community resources. Like, there are resources, there are strengths in the community. How can we uplift the community and then kind of have a way to have a more sustained support for that client, rather than just trying to navigate the entire system and finding where these supports even can be. So that's something that stands out as a difference for me from patient navigation versus link worker or social prescribing. It's 10:30, so I don't know how we're doing with time. 5. Okay. Okay. Yeah.
Thanks very much for your presentation. I'm Michelle Burley. I co-chair the Canadian Immunocompromised Advocacy Network. I also founded an online support group for immunocompromised people called Immunocompromised People Are Not Expendable. That's a lot of long words. Sorry about that. So first of all, just on the data question, I just want to confirm EMR, that's electronic medical records, correct? Thanks. And my other question is, so I love what you're talking about. I love what you're doing here. I think the social interaction, the community interaction is really important. From the perspective of the immunocompromised community, which makes up much of the patient population, there are many people who are still choosing to shelter to protect their physical well-being, which obviously is having a serious impact on their mental well-being. And I would also just, as kind of a side note, mention that some people are mistaking their choice to isolate as a mental health issue. So just kind of calling that out right out of the gate. I'd like to know what considerations and strategies you are taking into account for those who are choosing to isolate for physical health reasons.
I can share something that came out of COVID, actually. So COVID taught us that we don't have to be physically connected to be actually connected. So a lot of during COVID, a lot of the programs had switched to a virtual model. There are lots of virtual groups, lots of virtual support programs where you can join in from any situation. Like, to your point, someone who would like to isolate, but how can they still stay connected? That is one of the options that I see. The benefit of virtual is also that you could be at a bit more rural setting, but still be connected more broadly. So that's one thing that I'm hearing from some of our partners who are in Alberta, let's say, and there are some areas where it's hard to physically connect with people. Happy to hear any others.
Well, I was working at a community health center when the pandemic happened, and we were all dismissed and sent home. And then I went home for a week, and I was like, well, I'm not being redeployed, so I'm going back into the office. And we just switched over to virtual programs, and I was very skeptical. I was like, will this be the same kind of connection as we felt in person? And it was the same connection. And for lots of our folks who had disabilities, for older adults, for people who are immunocompromised, it's like those virtual groups continue. And so we had virtual creative writing drop-in, and the one that comes to mind too is we had a virtual stop smoking group, and I was like, will this be the same as it was in person? But the feedback we got was people were like, oh, this is what I look forward to all week. I had a shower, I cleaned up my apartment so it looks nice behind, and I got dressed up, and it was like, yeah, these virtual programs are just, and this was one of the great positive amazing learnings of the pandemic is, yeah, there's lots of ways to stay in contact, and it doesn't have to be in person. So those virtual programs continue. With our older adults, we have Senior Center Without Walls across Ontario, which you can access through your telephone. You don't even need the internet, and a lot of the programs are virtual or over the phone, or yeah, there's many ways to access programs.
Wonderful, thank you.
Thank you, everyone. It was a lovely presentation. So my question is for Shrija. I'm Harjeet Kaur. I'm a South Asian myself, and I'm a stage 4 cancer survivor, and I was struggling to find support groups when I came to this country. And as an immigrant, stage 4 cancer patient, and cancer being a huge stigma in our community. So how you help South Asian community people, because obviously mental health, anxiety, depression, it's also a huge stigma, around this community. So how do you guys provide those support services to those people, or are there any patient navigators who are, giving that information? Because language is also one of the biggest issues in that. So.
Absolutely. I completely understand where you're coming from. And I think that's one thing that is really core of social prescribing. There is no standardized prescription for everybody. Everyone's prescription looks unique to them. So something that could be a prescription for Natasha could be useless for me, and something that could be a prescription for me could be useless for Natasha. So that is how social prescribing tries to approach this sort of unique situations. The other thing is like I mentioned before, tapping into what's in the community. So someone who comes from a South Asian background, and how can we get them connected with the community where they feel more safe, they feel like they feel welcome, they feel warm, and they feel like they belong. So that is also something social prescribing really wants to focus on, and that's one of the strengths I think a link worker needs to have, to be able to read that individual as an individual. What is Srija? What is Natasha? Not like, here is a group of people who are going through this sort of problem. So I think that's how we approach this sort of unique situations in social prescribing.
My South Asian singing skills are not strong, and my hunting skills are not strong. Those would not be the right prescriptions for me, but the cross-country skiing is what works for me. So yeah, okay. And building that trust and having that trust. I wondered if we wanted to end with just like really briefly any calls to action or that people can take away.
I'm just kind of reiterating what I said at the end of the presentation, is just really being mindful of the language you use with Indigenous communities specifically, and then just reflecting on things that you can do as an individual as well as in your professional career to foster that cultural safety, and being mindful that cultural spaces, and actually the presentation before outlined this as well, that cultural safety, you may think you're creating a safe space, but the person coming into that space is really who can say whether they feel safe there or not. So being mindful of that and things that you can do to build that awareness.
Sure. I think my call for action would be, don't think that you are not ready to start. There's strength in what you're doing already, and I think tapping into the strength in what you're doing already and starting from there is where we should start. Like there's nothing, I don't believe in like there is a perfect time to start something. It's always like there is a need for something and then you just get started. So think about what are some of the resources, the strengths that you have in the work that you are doing, and how can you take that and support your communities in a way that also aligns with, like the person-centeredness. So I think that would be something that I would leave with.
And I would say, like right now, the Alliance, we're advocating with the provincial government for funding for link workers. So if you want to talk to your healthcare team about social prescribing, if you want to talk to your MPP, your MP, and like talk about how this could work, I mean, I see there's a lot of strong leaders at this event. So just building up your own community, which I think everybody is already doing, but connecting to your own community and building that community, those would be my calls to action. Thank you very much.
Thank you so much for joining us, and there's a lot of thinking going on in the room after your amazing presentation, so thank you. And just letting everyone know that we're taking a very brief break. There's some snacks out, and just to be back by 1:45 so that we can get started with our data discussions.
When we look around the world's best health systems are powered by data. And we also know that patients bring a very unique insight that better helps us to understand that data. Their lived experience helps to explain our findings. And quite frankly, it ensures that our work remains relevant to the decision makers who often work without having patient voices in their ears. And so I think it's an important influence that we want to nurture and cultivate. So one of the things that came out of this Pan-Canadian Health Data Strategy was a recognition that CIHI needs to do more. And so we were given extra money from the federal government to begin to move forward on several large modernization initiatives. We've been around for 30 years. We've been doing all kinds of really important work to strengthen the caliber of the data in our publicly funded health system. But the challenge post-COVID was we've got to do better. We need to move faster. And my colleagues and I are feverishly working on a transformation plan. Actually, we have our CIHI board meetings tomorrow in Ottawa, and we'll be presenting to them these initiatives that I'll briefly touch on for your benefit. I won't get into all the details unless there's questions. Happy to dive deeper then. But we see ourselves, we're a health data organization, but we're actually a health organization, period. We just tend to focus on data. And we see our mandate as helping improve quality of care by providing better data. It's as simple as that, and it's as complicated as that. And we really have made a concerted commitment to making patients the central focus of our work. We've been developing those focuses or foci over the last few years, but it's become even much more important to us as we go forward. So here is just a picture of some of the things we're working on. I'll start at the top and just quickly around. So connected, a health data ecosystem that's connected. For those of you who have experience, you'll recognize that your data doesn't follow you very easily. And if those of you with serious chronic conditions or other diseases, you often hear stories of people carrying binders of their medical information so that stuff doesn't get missed. And so the idea here is that if we adopt data standards, and that's the term we use, it's just a consistent definition of what something means that we all agree on, and we all agree we're going to report it and measure it the same way. It's not as prevalent as we would hope. We're focused on that. Creating that common language, it makes it easier to share the data without having to sling a binder along with you. That's what that's all about. We work very closely with one of our sister Pan-Can health organizations, Canada Health Infoway, on a whole program of work called Connected Care. We're producing the data content framework. Where is Natasha? So we're very intrigued, as Paul's questions would have alluded to, about the social determinants of health, the survey material, or I'm getting the phrasing wrong, excuse me, but accessing that type of data to enable social prescribing or whatever we come to call those services. That should be part and parcel of our framework. It's not just acute care or primary care, as important as those are. So I was really intrigued by that as well. So the next one is all about accessibility, and it's for those of you who do know CIHI and you've tried to navigate our website. Before I joined CIHI, I used to do the same thing. I still do a little bit, but it's Byzantine. It's very hard to find what I need when I need it. So we're really investing a lot of resources to make it more intuitive, that you shouldn't have to be an epidemiologist to read a report or an analysis or something that speaks about wait times for surgery in different provinces or whatever the case might be. I've touched on data literacy a little bit, but to me that's at the heart of, we need to do a better job of making that data easily accessible and understood, and that's all part and parcel. And it's not just for patients and patient advisors, like politicians, policymakers. A lot of people are not that data literate, quite frankly, and that's not a criticism, it's just a reality. If it's not your thing, it's not your thing. So it's incumbent on us, those of us who work with data, to make it easier to understand, digest, and take action with it. Comprehensiveness is another thread to this, and this is really, there are so many diverse data sources, and just knowing what happened in a hospital without knowing what your community family physician or nurse practitioner is doing versus what your counselor might be doing, if those are not linked and able to follow you throughout your journey, it's not very valuable, or it's not as valuable as it could be. Timeliness was the big COVID driver for us. We've been collecting data for years, but it tends to be quite old. There's a lag just because of how the data gets collected. With the wonderful advances in technology and things like application programming interfaces, if you really want to know, I'll explain what that is. But there's a lot of ways to get the data faster and eliminate a lot of the manual coding that a lot of healthcare organizations subject themselves to get it. Good news is we think we can speed up the data so that rather than telling you what happened 6 months ago, we can tell you what happened last week, and within organizations even on an hourly basis. Relevance matters. Data is great, but if it doesn't have the context, it's not very helpful, is it? And so that's another area we're working on, making it more contextualized, telling the stories that the data reveals to us, and not just us telling those stories, but helping people to be able to tell their own stories. And then lastly, perhaps, is that it must be trustworthy and trusted, which means we have to develop this in a way that people feel that it's been done with integrity and respecting privacy. Those are sort of fundamentals for CIHI. So I've talked a little bit about the Pan-Canadian Health Data Content Framework. I will resist going more into that unless there's interest. I know some of you are participating or engaging on that, and we welcome that. And some of my colleagues will be sticking around for the remainder of the event, happy to talk more. So let's talk a little bit more about how we are working with patients and families. And I'll preface this by, see patients as in quotes. It's not just patients, it's clients, it's residents, it's family members, it's caregivers with lived and living experiences that we want to engage with. We've been cultivating this skill or this ability for the last few years, but we really want to bring the patient voice even more into our work. We see it as foundational, actually. And there's growing evidence that patient involvement really helps with health research. And so you'll see we see patients as representatives, as advisors, as partners, and as leaders. And I won't go through those. I'm happy to give examples if there's interest, but whatever role we ask for, we want people's engagement to be meaningful, purposeful, and authentic. All contributions like these, they really do influence our decision making, and I'll share a story with you in a second that's quite on point to demonstrate the power of patient voice to our work. It's not just ticking boxes, as somebody joked about at the break. So here's some headlines. The impacts of patient partnership are on full display if you read the papers or follow media coverage. There's a ton of work that we're reporting on that helps communicate to the public in a meaningful way. We see patient partnership as integral in helping us tell those stories. We've just recently released a report on what we're calling the common indicators that help paint a picture of primary care across the nation. And you'll see these report by province and territory what it's like, how many people have access to primary health care, for example, or how are we doing on improving the supply of physicians and nurses, or reducing wait times for surgeries, access to mental health and substance use services. What are we doing to modernize our healthcare information systems? How many physicians are able to share data readily with another physician in your circle of care? So we're tracking and publishing that, and it's sparking a fair bit of interest. But what we've really learned, and I feel like I'm repeating it, but I think it merits repetition, is patients have been instrumental in the development of this work. And it's really helped drive the importance of this reporting to people who don't necessarily take it personally. So the story I want to share with you, and this goes back a few years, so for those of you who are a little older like me, you may recall when Paul Martin was Prime Minister, and he announced a big, I think it was $10 billion fix for a generation for healthcare. And as part of that, what the feds wanted in exchange was that provinces would agree to report on what we called the shared health priorities. And so this is almost 10 years ago, I believe. And so Health Canada, wanting to drive that process, called their PT partners together. So you can imagine you've got 14 officials from every government in the country in a room, and then we're going to argue about, well, how do we measure wait time for surgery? And it turns into a big intellectual debate, and if you work in government, you'll know all about the FPT bun fight, as I call it. There's a lot of adversarial tension. It's just the nature of intergovernmental affairs. And so Health Canada labored mightily at this, couldn't get anywhere. It just was a long intellectual debate. So then they turned to Kai and said, can you guys take a shot at this? So we did, and we entered that room. First thing we did was we brought in people with lived experience. We also brought in subject matter experts on how do you measure access to mental health and substance use. We brought patients or people who had personal experience with this. And it was, it was quite amazing to see how the conversation shifted when you had people talking about, I can't get my kid in for counseling. And, sorry. But it was quite revealing to see how, even the coldest-hearted bureaucrat couldn't ignore that. And that really unlocked the conversation and allowed us to get to meaningful agreement on how do we report on this. It really knocked down a lot of the turf and the BS, which I was quite pleased to see. So it really impacted the process, and everybody has a health story is what I like to say, and that humanized it. So I thought that was worth sharing. Thought you were going to bring me a tissue. I want to talk a little bit more about CIA's commitment to equity and Indigenous health priorities. How are we doing for time? Good, okay. So CIA's data is rooted in the pursuit of health equity. And we've heard lots of conversation in the opening session, and I know the panel that follows me will speak to this as well. But we've developed a lot of guidance on equity stratifiers, whether that's demographic characteristics like age and gender, income level, race, Indigenous identity, of course, that can help identify those population subgroups. And once we have those in place, you can drill down into the data, and you can really identify and report on some of those potential inequities and inequalities that exist between the subpopulations, and measure those differences in health and healthcare. And that allows us to tackle them in a more thoughtful, responsible way. I would note we've developed a toolkit to help us onboard patient partners when they join us and participate in projects and provide guidance to support their physical, mental, and financial well-being. We recognize that talking about one's healthcare experience or the experience of someone you might represent can be tough. We also acknowledge that when you give your time, we're taking you away from other things, your job or your otherwise busy schedule. So we want to do that very respectfully. So we've put a lot of thought in these guidelines for supporting patients, and look forward to sharing them with you if you haven't had an opportunity to see them. We're also developing what we call an engagement framework on how to better involve Indigenous peoples and communities as patient partners. And I would note we already have several active engagements in flight, but we want to do an even better job of that. So with regards to working with Indigenous partners, we really want to better understand and respond to their health information and data governance needs as they define them. And that's really important to emphasize. Again, nothing about us without us. We have lots of ideas, but it's not really our decision, quite frankly. So forming those partnerships that engage people locally, regionally, and nationally is one of the things we're turning our minds to. In particular, working on respectful governance of Indigenous peoples' data as well. So we're very mindful of data sovereignty principles, particularly as they relate to First Nations, Inuit, and Métis communities. I will highlight one piece of work we're very proud of. We're developing cultural safety indicators, which really was sparked by the Joyce Echaquan incident and the fallout from that, and that we got endorsement from ministers across the country to advance work on that. It took time, but I'm pleased to report that we have a table of 8 strong, wise Indigenous women who have driven a process that allowed us to begin to point to things we can actually measure that can report on at a facility level cultural safety. And so that's something that can be fixed. And so as we report on the other things like access and wait times, as one of my colleagues said, well, this is kind of like table stakes. If I don't feel safe or respected, I don't care about wait times. I'm just not going to go to your facility. So that's, I think that's quite powerful, and we're getting close to, it's out for consultation with Indigenous partners and communities, but we're really looking forward to be able to publish that. So I hope you're hearing a very strong commitment from CII on both equity as well as Indigenous health priorities. We really think these are going to be important if we're ever going to be able to tell the story behind the numbers. And so we think these are integral pieces to help people reach their fullest potential. And so my last slide, and I hope you'll see this as a bit of a call to action, is that if I can leave you with 3 ideas to consider. First and foremost is to champion patient voices. So it's a bit of a paradigm shift. I think for many in this room, it's already been painfully aware for you, but see yourselves, patients, as the drivers of change. The importance of convening conversations at summits, very much like this one, now more than ever, mobilizing patient coalitions that elected officials, quite frankly, cannot ignore. And I say that as someone who works for a largely government-funded entity. More importantly, empowering informed choices. People need to advocate to have access to clear, accurate information that you can understand, that allows you to make confident decisions about your health or treatment of those you love. Ownership of your health data is too important to leave to the politicians, as I like to say. I think now more than ever, Canadians need to demand this. And then the third thread to this is really about collaboration for change. To me, true change requires a different way of working and a different way of organizing ourselves. True partnership with providers, policymakers, citizens, patient advocates. It doesn't work unless we all come together on this. So this slide refers to a thing called the Healthy Data Collective. This is something CIHI has supported. We don't run it, we don't own it, we're supporting it. And that's a very important distinction. It's a new initiative for us, and it's really dedicated to trying to transform Canada's fragmented health system and its health information system into a more connected, inclusive, and effective network that benefits all Canadians. So we see this as a grassroots movement, and it really does include all stakeholders in the discussion. So we're using what's called a collective impact approach, and some of you may be more familiar with this than I am, but essentially it's a grassroots movement. And so it's patient voices, it's retired hospital administrators who are frustrated that they were unable to address these things, and all points in between. And it just creates a community for people to better understand these things and maybe to find a common voice that insists that we do better on this. So I would encourage all of you to visit this site. We do, CIHI facilitates lots of awareness raising educational topics around how can sharing data save lives, the importance of data sovereignty, etc. So it's a real great place to get a lot of learning about what's possible, as well as plug into a burgeoning community of voices demanding that we do better as a country on this. One thing I'll highlight for you is a thing called the Canadian Health Data Charter, which speaks to your rights, or what should be your rights when it comes to your health data. So I'd encourage you to look that up. And the website is healthydata.ca. I'm sure it's somewhere in the materials. There it is. So I guess I would just, in closing, thank you for your interest in this. I know data can be very, and I say this as a data guy, it can be very boring, very opaque. I work with a lot of data nerds, and they're great people. But the importance of this transcends being a data scientist. It's actually about empowerment, and hopefully you will support us in that and participate in the data side of these discussions. So with that, I will conclude, and thank you so much for your time and interest.
Okay, thank you, Steve. We'll be saving questions till after the panel, and then we'll bring up Steve, and we'll meet with the other panelists. So, if I could ask the three panelists to come up, Jamal Demeki, Sharon Davis-Murdoch, and Dr. Veronica McKinney. Oh, okay. Okay, Sharon Davis-Murdoch and Jamal Demeki are online. Okay, I'll say a few words about each of the presenters, and then I'll let them begin with Jamal, followed by Sharon, and then Veronica. Okay, so Jamal Demeki is a distinguished researcher at the Wellesley Institute, boasting a comprehensive research portfolio in the health sector. His expertise extends across biomedical, community-based, clinical, and health systems research. He's been instrumental in transforming the management of health services and data across Canada and the United States. And at the Wellesley Institute, he is at the forefront of initiatives that emphasize the use and community governance of socio-demographic data. His work continues to shape the landscape of health research and data management. Sharon Davis-Murdoch is a social justice champion. Sharon's political science background and public policy experience informs her work at the community level. She is a founding member of the current co-president of the Health Association of African Canadians. Among her public policy accomplishments was the development of the first provincial guidelines for culturally competent primary health care in Canada. She's also the co-manager of the Association of Black Social Workers and the Health Association of African Canadians Black Health and Wellness Initiative. She is also an advisor to Halifax Immigrant Partnership and secretary of the Dartmouth General Hospital Foundation Board. And last but not least, we have Dr. Veronica McKenney. She's a director of Northern Medical Services, College of Medicine at the University of Saskatchewan. Veronica is of Cree Métis descent and provides leadership in health development, working with rural and remote northern Saskatchewan Indigenous communities, the Saskatchewan Health Authority, and various health organizations, tribal councils, and bands to support and promote the continued evolution and advancement of healthy communities, families, and people. So without further ado, we'll start with Jamel Demeki. Okay, go ahead.
Okay, perfect. So yeah, hi everyone. My name is Jamal Demeka, researcher at the Wellesley. As mentioned, I'm also currently getting my master's in artificial intelligence and health systems at University of Toronto. So my entire life revolves around data, and yeah, I'm just here to talk a bit about some of the work that we're leading at Wellesley and how it's relevant to equity deserving communities. So if I can go to the next slide. So the way that I'm going to frame this is I think it's always important for us to understand the why. Why do we care about, in this case, race-based data? And then also trying to learn about community governance mechanisms that have been provided to us and how they're being implemented. And then we can talk about different examples across the country as well. So if I can go to the next slide. And then the next one. So at the beginning of the pandemic is where I'm going to take everyone, where we understood that there was a health crisis. And we saw the dramatic impacts that it had in people's everyday lives. The thing is, even as was just mentioned, we're thinking in Canada about how we can use data to appropriately respond to dramatic either health disparities, and in this case, COVID-19. But unfortunately, at the time, we didn't have race-based data to be able to explore the impacts of COVID on racialized communities. But we could look towards the United States and the United Kingdom where this was collected and reported, and we saw that there were high rates of COVID-19 transmissions, hospitalizations, and mortality rates for Black populations. And then, of course, later on in the summer, we saw kind of the rise or the resurgence of the Black Lives Matter movement in response to the murder of George Floyd. And so Black communities then had a kind of dual crisis going on, trying to grapple the same thing that many other people are doing and trying to keep themselves safe and protected from an infectious disease, but then also, really trying to understand for themselves where does race fit into my experience in this world, and how can I better protect myself from the multiple things that are coming my way. So with that being said, and understanding that there isn't any information available, that's where the Black Health Equity Working Group came to be, which is essentially just a collaboration between a bunch of different advocates in the Black health space, whether they're clinicians, community leaders of community organizations, community members themselves, academic researchers, and the like. And all of them came together and started to push for the race-based data collection, writing a letter actually to the provincial government at the beginning of the pandemics, understanding that, again, the exact same trends that we're seeing everywhere else most likely are going to happen here. The next slide. And so, again, when we think about race-based data, we need to also understand that just having the information is not necessarily the goal here. We want to really understand how we can use this data to identify disparities, monitor and in this case, it was monitor how COVID-19 was impacting Black communities, but also understanding that there was, a vaccine to come, but then thinking about all the other types of interventions, non-clinical interventions that are being used, and thinking, are these effective? Are they working? And who are they protecting and who are they not? And all in the end, what this would do, right, is create a transparent health system. And that's what the Black Health Equity Working Group centers themselves around. And then kind of the tagline is, evidence-informed, community-driven public health and policy solutions. And that's kind of what they established themselves to try and bring, specifically for the advocacy of Black communities. And so next slide. Yeah, and as I mentioned, there wasn't any data available on an individual basis at the time, understanding. And so we wanted to understand, of course, what are the implications of COVID-19 for different communities here in Toronto. And I think what's really helpful to understand is just because you don't think you have all the information available does not mean that you can't start somewhere. And I remember someone actually just said earlier, right? Like there's no perfect time to start, right? You can just do it. And so that's what they tried to do. They did an area-based analysis, understanding, and this is the map of the city of Toronto with its different neighborhoods, that there are different demographic changes across these neighborhoods. And once they did analysis, looking at COVID-19 cases, they saw that there was an up to 10 times difference between the lowest and the highest neighborhoods. And when they looked at them, they understood that the best predictors for an area rate was the percentage of the population that was racialized, living with low income, and also those who live with or live in overcrowded households, which isn't frankly surprising when we again take a social determinants of health approach and understanding that, yeah, if you don't have a place to isolate yourself, then that's going to be challenging. And then also thinking about the distribution of resources at the time, right? Who's able to have access to masks that early on? If you remember, people were using cloths and, trying to be creative, but again, who has the time and the ability to do this? And so the next slide. And so then that area-based analysis started or was part of a larger movement. So in May of 2020, we were able to see here that the London and Middlesex Public Health Unit kind of started collecting race and ethnicity data, and then soon after Peel Region and then the City of Toronto. So you could see that it was just one after the other, understanding that this was going to be important data. And eventually, once people started doing something, what we then saw is the change in the provincial legislation to allow the collecting of race-based data at that level, right? And so all of these public health units then had to shift to submit their data to a public health or a provincial portal to allow a larger understanding as a province as to what's going on. And then once that data was made available to these different public health units, I can speak to at least here in Toronto, what they're able to do is use that data to consult with communities and develop an equity-focused plan or different equity-focused plans, right? There was a release of funding that happened that summer, right, that allowed different community organizations to mobilize in the ways that they think are useful to them. And so Black community organizations were able to do that for themselves. And so if we look at the next slide, what I will be able to show you is this graph here that is demonstrating the rates of COVID-19 for different racialized communities in comparison to the white population across from June, which is at the very beginning, and to December of 2020. And so all of those different lines indicating different communities, right? And the numbers on the side, again, showing kind of that difference, right? About either 2 times, 4 times higher than the white population. And so if we follow that black line, the blue line, we're able to see that Black communities had, an increasing rise in COVID-19 kind of discrepancies or rate ratio compared to the white population. But once that funding was available and the data was being used, if we look at August, right, we're able to see the kind of dramatic drop in the rate ratio of COVID-19 and it being stable or continuing to decline, essentially showing that once we have the data available and if we use it responsibly, right, and also involve community in the development of our programming and in our interventions, we can actually see a quite effective reduction in inequity, health inequities. And that's what we want to see. And that's why we believe that this data is very important to collect and to have. And at the same time, there are other things to think about. And so if I go to the next slide, I want to now build in the understanding of, okay, great, having the data is one part of the puzzle, but we also need to think about where communities fit into all of this, and how does the decision-making processes need to change to reflect how a community should have ownership of their own data. And that's what the governance piece is talking about. And so in the next slide, what I really want to emphasize is that trust is incredibly important when it comes to collecting data in Canada, but then also the world. Right? Everyone, I think, is pretty familiar with joking about, hey, I just talked about this one topic with my friend, and then all of a sudden I'm getting an ad on my phone. Like, we're constantly being, asked, will you allow me to collect your cookies? Is that something you're okay with? It's like these decisions that you're having to make day in and day out, understanding what should I do with my data? What is going on? And when we look at how privacy is understood here, it's actually on an individual basis, right? What are my rights as who I am in terms of understanding, who can have my data and who cannot? And some population groups are concerned about the impacts of big data on their communities more than others, right? And that is drawn from practices of how data can be used to, influence people's health insurance rates, not or being afraid of how their mortgage approval rates as a community will then change. And the thing is that data is now understood as a group. If I go back to that graph that I showed you earlier, right? If you remember that, sorry, then you're able to see that there's no individual there. You're not able to identify who I'm talking about, but I'm still making a narrative and I'm speaking to a community group. So how do we understand the rights, right? When we're talking about an entire group. And also, if we're thinking about, hey, I want to collect information, which is quite valuable for a lot of people, and we have to think about the quality of data that we want to have in terms of it being complete. Otherwise, I can't say that this data reflects the population group that I'm talking about. It reflects maybe a very small part, but I don't know. And if then we don't pay attention to building that trust piece and no one provides the information to you, right, then we're not able to use it effectively. And that is what that story showed, is when you build trust, how it can be. So if I go to the next slide, the focus of the Black Health Equity Working Group, if you remember, is on Black communities. And, there's specific experiences of Black communities that, if I were to even focus on the COVID-19 pandemic, we saw earlier on that there were discrepancies or disparities in COVID-19 outcomes. The thing is, what we saw early on is that people were making interpretations saying that perhaps Black people are genetically or biologically, more likely to contract COVID or to be hospitalized or to die, right? And that is not factual. That is not shown in the evidence, and that's something that a lot of people knew then, and we definitely know now. And we know we have to look towards the social determinants of health. Do people have adequate housing, income supports, food, and those sorts of things? And so the data being collected, can be used to harm or drive narratives that cause harm to these different communities. And in the end, what a lot of people feel is that they're giving data, but then it's not having any type of community benefit. And even more so is the fear that the data will be monetized or used for any type of political gain. And so on the next slide is what we can then think about when we want to talk about how do we rectify or reconcile all of these things. And so the EGAP framework, which stands for Engagement, Governance, Access, and Protections, it was started by the Black Health Equity Working Group as kind of a point for us to begin thinking about data sovereignty. And what does that mean? We're just talking about the ability for Black communities to have ownership and control their collective data so that the narratives that come out are actually going to be accurate and reflect the lived realities of Black communities, and in that way be able to be used effectively. And so what do these four letters mean? Well, on the next slide is where we can then talk about, engagement, right? This piece around starting conversations with people around data, specifically about data and its collection, its management, analysis, and use. It was mentioned earlier, right? Data literacy. I think a lot of people will benefit from being able to be immersed. Data is very relevant to many people's lives. And so as people understand what data is and get those engagement pieces, people will want to start making decisions. And that's what that governance piece is about. Constructing a community governance table at whatever level is appropriate for whoever's trying to use EGAP, so that the communities are actually able to say that this is a responsible use of the data and this wouldn't be. And in order for this table to be effective, right, they need to have access to the data. And then not just access, but being able to understand what the data means. And that's where the literacy piece comes again and the capacity building that's required. And lastly is then also, of course, making sure that we're protecting the data in the way that the governance table says is necessary, right? There's kind of those mandatory things in terms of regulations or in terms of the law that you'd have to do. But then we have to think another layer, a community governance layer. So on the next slide is when I'm going to start talking about different efforts, beginning with here in Ontario. So in the Toronto region, Ontario Health wanted to pilot EGAP, that framework that I just showed you. What does this look like when you're actually going to be using it? And so what they did is they thought, okay, well, let's follow the journey of very specific early adopters, understand what types of strategies that they used, and create, in the end, an implementation plan approach that can be, spread and scaled across the region. And so what we found then, at least, and you're able to see this on the website, is that there's a lot of work that needs to happen at the earlier phases. So we want people to understand that building organizational readiness, asking the questions about what type of data you have and the way that it can be used. Those are important things that you need to spend time on. I think when we see and talk about a community governance table, we believe that that's something that everyone should be expected to do within a year of starting this initiative. But if you rush this process, it's not going to be effective. You need to do it meaningfully. And then also as you engage with communities, you're going to understand that you're going to have to slow it down. And so, I guess I'll save some things for questions, but there's a lot of learnings that I would invite people to look on in that report. And then now on the next slide, what I would want to start talking about is also another initiative that we've been doing. So we have been engaging with lots of different organizations that have been interested in collecting sociodemographic data. And we saw a lot of federal agencies that are invested in its use. So, CIHI, which, we just saw over here, but then Economic and Social Development Canada, ESDC, the Federal Anti-Racism Secretariat, Public Health Agency of Canada, and StatsCan. And then also if we go to the next slide, what we're also able to see is that at different timelines, we're seeing provinces at different stages collect race-based data, right? Nova Scotia very, early on in the fall, doing it by the health card. We're able to see in Manitoba that this data is being collected at point of contact. And in British Columbia, we're seeing a survey being launched and then being used to understand the demographics of their province and how that impacts the use of their services. So there's lots of different approaches. There's lots of different plans that are happening across the country, but it can get very confusing then if we want to bring all of this data together. I think that's something that we just heard about, right? Is it's kind of clunky, it's kind of separate and disparate, and we want to ensure that there's some type of harmony between us. So in the next slide is where I can then kind of talk about how, as Wellesley Institute, what we've been doing is convening a space for the cross-pollination of ideas and relationship building between all of these different initiatives. So we have both, a growing network group where we allow people to talk about the work that they're doing, ask questions with each other, so that at these earlier stages, that there's some sort of alignment there in the collection, use, and governance of data. And then earlier this year, we also did have a summit where we were able to bring people here in Toronto and allow kind of a profile to be set so that people understand, hey, the narrative is that Canada does not collect this information, that we don't do this, but that's actually now wrong. There is work happening, I think what we need to do is turn our attention towards them, highlight them, and understand how we can, lift them up and engage with them in a way that now becomes the narrative. Because the work is changing, our understandings of the reality needs to change too. And so in the next slide is where I'm just going to talk about another piece of work that we've done with the City of Toronto, where they wanted to establish a Black community governance framework. And so we worked with them to engage with Black community members, experts in the tech, legal space. We talked to people in education, in housing, shelter services, children's services, all to try and bring all these pieces together, because we're not just talking about health data at this point. We're talking about lots of different pieces. And so as a municipal government, how can they bring those pieces together? And so we had principles laid out to help people understand, okay, what are the reasons why we're doing this, which is data being used for progress, accountability, and transparency. And I'm not going to go too deep into it, but just there are objectives there. The first one talking about the importance of community governance and engaging with communities. The second one is getting your house in order, right? But we need the technological infrastructure to be responsive to what a community governance table says, because there's no point in doing this if you're not able to change the way that you manage data. And lastly is using that data for the reasons that community governance said. So going to the final slide, I think what's important is for us to understand that the collection and use of sociodemographic data can be used to improve health. We need some type of alignment on how we're doing this and how it can be collected and governed, and that there are lots of different models and practices around community governance that are happening that offer that promise of improved big data sets and data justice. So thank you.
Thank you very much, Jamel. We will have questions later after our presentations. So I'd like to call to the mic Sharon Davis Murdoch. She's speaking on the connection between Black health data and the need for responsible data sharing practices. Sharon?
Yes, good afternoon. It is afternoon here, and I think it's almost afternoon there. I'm very pleased to be with you from joining from Nova Scotia. And indeed, I am very grateful to the team for the invitation to present to you today, and Sylvia's team and Antonella, Leah, Kathy, Katie, and the interpreters, and Sylvia as well. So thank you for that. Happy to be with you and also to kind of tell a story that is Nova Scotia specific, with a hope that we can expand our work and connect with people like Jamel and organizations like the Wellesley Institute and yours as well, to move us much further ahead. So with that, let's go to the next slide. It is important, I think, to begin at the beginning. And so we have to recognize that anti-Black systemic racism is a backdrop for all of the things that we're talking about here. And the reality is for us as a people, and we are not a monolith, we are very, very diverse within and among and across this country. But we share some historical and lived realities. And the historical realities, of course, include enslavement, segregation, and discrimination, and the everyday reality of discrimination, microaggressions, inequities, and the combined social and structural determinants of health have to be understood as our lived reality. And indeed, with all of that, we have a health system that has in the past and still does reflect our response, the trauma that we've endured as a people for since since the beginning. And so there is mistrust. There is mistrust of the health system. There's mistrust of information. There's mistrust about a system that we are not participating in, that we are not governing, that we have very little say in and about. I think Jamel spoke so well about the disproportionality that affects people of African ancestry with respect to chronic disease, and the pandemic shone a very harsh light on those effects, on those impacts. We were able to see, and I think Canada might have finally seen, the kinds of inequities and disparities that exist, and not because we are sick or pathologically inferior, but because of those that history and those social and the combined social and structural determinants of health. So we kind of lived sicker and died sooner as a result of that pandemic. It has affected us across the African diaspora, Canada being part of that, but certainly not all of it. Just everywhere you go across the globe, we were disproportionately affected. And so we at the Health Association of African Canadians, and in the introduction, you heard that I am a co-founder and the co-president of I will call it HAWK. That's the acronym. We certainly describe and we promote the need for systemic cultural competence with specific approaches, and we define cultural competence as the awareness, knowledge, skills, and policies, underlying policies needed to meet the needs of people across their diversity, and with that, people of African ancestry, very specifically for the work of HAWK. And indeed, part of this backdrop is also 24 years of advocacy. 24, can you imagine that? 24 years of advocacy to establish race, ethnicity, and language identifiers in statistical data. We have been at this. We have recognized this need to be on the radar screen for our health and our needs to be recognized, to be responded to. And we know that data is necessary. In fact, government continued to tell us, while not allowing us to have this data collected, they would tell us that they could not make decisions without evidence-based data. So on the one hand, we were prevented from collecting it, and on the other hand, we were punished because we didn't have it. So yeah, you can appreciate that this advocacy has been exhausting, and we are now at a place where finally the data is being collected, but we are not governing it. So the years of advocacy was clearly to have this data collected, not just race, because we are a people who are diverse, as I have said, and we understand the intersectionality of our experience, of our lived reality, race, class, gender, all of those things, interdependent, our sexual orientation, our identity throughout all aspects of our lives needed to be part of this capture. But we always and specifically talked about race, ethnicity, and language in order to inform decision making, to have our health programs where they existed, and there are far too few of them, but to have our needs met and to have them funded and for services to be available equitably. And was said by colleagues previously during this session, there must be nothing about us without us. And so we truly believe in that. So in Nova Scotia, the Fair Care Project came about, I would say not exclusively because of the advocacy of Hawk, but in large part due to those 24 years of advocacy. So I'll use the next slide now, if possible. So indeed, we have progressed tremendously in that two governments, the Liberal government originally under Premier Rankin, and then under Premier Tim Houston, the work has continued of the Fair Care Project. And so in order to inform that, Hawk was called on to basically host and organize outreach sessions for African Nova Scotian and Black communities in Nova Scotia, both in person and online, from November the 17th of 2021 to April of 2022. And those were sessions everywhere across the province. It was really important that we talk to our rural brothers and sisters who are woefully underserved with respect to any kind of care, but very specifically culturally competent care for Black people. It's not where it needs to be across this province. So those outreach sessions took place, and we had many people involved, both in attending and in hosting those sessions. We made sure to involve community people who people trusted, who people were familiar with as part of that work. So we did that in Nova Scotia. And I would say at this point, a lot of information, a lot of data has been collected, but it has not been shared. And it is important that before that the data of Black people is shared. We certainly want to have some work done around governance. And this is what my presentation will focus on eventually. I do want to say that nationally, as we were working in Nova Scotia, and as we have advocated for 24 years, we advocated not only provincially, but nationally. And there has been, very slow response to that. I think as a person who is a leader, a community leader, and listening to our people and listening to sort of the powers that be around these issues, what we find is that we're told by government representatives, and believe me, I have nothing against government representatives. I worked for the provincial government in Nova Scotia for 24 and a half years, and it was, very proud to be there. So it's not about that, but it is about the fact that governments would say that Black people really don't want this data collected. And so that's why they're not doing it. And they would say that to us when we were advocating for 24 and a half years to have it collected. And we would say, well, who are these people who don't want it? Perhaps it's about not the fact that data is collected, but how it's collected and how it's used. That's the problem. And we are advocating for it to be used safely and to be collected appropriately. So nationally, we would hear that as well. And We are now at a stage, I understand from listening to the Black Opportunity Fund webinar that was recently held, that there was a snapshot on Black health nationally in 2017, and that there will be one again soon. We look forward to that. So, and we are appreciative of the progress that's been made in that area. But unfortunately, the information that we have where Black people might be able to, connect some dots in terms of overarching health status doesn't give us the granular information we want and we need. In Nova Scotia, we don't know where we fit in the Black Canadians sort of lump of information. And certainly, if you live in Cape Breton and you are a Black person, you'd have no idea if you are being counted among that group of Black Canadians and how it is that you would show up in that data. So what we're looking for is a need for more granularity in this data. And in Nova Scotia, we hope that what has been collected will provide some answers for us. But as I've said, there still is little or no governance of that Black health data, and so we need that in order to move on. Next slide, please. Can we have the next slide? Okay, great, thanks. So when I referenced how we had sessions across the province in Nova Scotia, talking to people about the collection of data and the importance of that with the Fair Care Project. And so in talking to them, we told them that we would make sure that we heard them and that we would pass on their concerns to government. And so I have a synthesis of the kinds of questions that we heard across the province. And Hawk is still kind of waiting for these answers. And what people wanted to know is, who will own our data? How will this program reach our most vulnerable? What will be done to educate healthcare professionals? Will I be able to select more than one category? How will the collection of data benefit or serve our communities? How will the government work to build trust with communities? Who will govern how this information is used? Will communities be updated on the progress of data collection? They wanted to know. Is it possible to create a Black Research Ethics Board? And how will my information be kept safe? And these important questions still remain. They still remain because we are waiting for there to be some structure in which we can have governance for Black health data. And of course, Hawk recognizes, I think, have we moved on to the next slide? If we could. Hawk recognizes that we need to monitor our health and build Black health infrastructure. Health data is essential for evidence-based decision-making, for funding for programs and services, and those services to address chronic disease, including including skin diseases and disorders. Very important. And so necessary for the better or the improved health outcomes of Black Canadians of African ancestry. And so with the health data policy that comes with governance, again, we need to be there because there should be nothing about us without us. And we need to have policy representation at that table, at the highest levels of the system, and at all levels. And I've spoken about before about the need to have this with a culturally competent framework and culturally specific approaches, whether we're talking about clinical approaches to address these needs that we have, structural improvements so that we actually have a structure that addresses structural anti-Black racism, and indeed the prioritization of our research as well. So now what? Next slide, please. Literally, now what? While Nova Scotia has begun collection of self-identified race-based and language-based data through health card registration, there is no clear governance structure for the interpretation and dissemination of Black race-based data. So the lack of clear data governance for the data that's being collected under the Fair Care Project prevents these data from being completely ethically collected, analyzed, and disseminated. And Jamel talked about the importance of having them interpreted in a way that is addressing the biases that are in the system, the anti-Black racism that exists. We want to have data disseminated and shared with not only Black communities, but all communities, that is a fair representation and a just representation of our health status and what our needs are. So it may interest you to know that HAWK has applied only very recently for the Nova Scotia government under a community fund. We are wanting to address this gap. We want to work on developing a processed based tool that will be able to be used by the province in its efforts to collect this information, this data, and for Black Nova Scotians in Nova Scotia to be a part of it. And we plan to achieve this through the activities such as conducting an international and national environmental scan of existing Black race-based data governance frameworks. We want to look at best practice out there or the most promising of practices. We want to develop a data governance structure for the collection, interpretation, and dissemination of data. We want to disseminate the data governance framework to key target audiences through planning and developing this information. We want to have a number of events to do that. So in closing, HAWK has completed extensive engagement and consultation around race-based, and as I've said, race, ethnicity, and language identifiers over many, many years, decades, in fact. And this includes our own research and policy work alongside the Nova Scotia government's development of the Fair Care Project and their health equity framework. And so we are going to, with the province's support financially, if they choose to support this project, we will partner with On These Shoulders Research Collaborative out of Dalhousie and work to provide a tool through which government will be able to work toward Black data governance. And of course, we hope in the future to collaborate nationally, as I've said, with Jamel and EGAP and all of the work that's going on so that Black people in Canada can have data that supports their improved health outcomes through the work of government and through the work of our communities. So with that, I thank you so much for your attention.
Okay, thank you very much, Sharon. Okay, so we'll hold questions for the end again. So I'll introduce our next speaker, Dr. Veronica McKinney.
Hi there. So I thought I'd change up the paradigm a little bit just to get us thinking about how to do things in a different way. And the only difference is I'll be talking without any slides. And I just want you to think about this in a way. At this time of year in our Indigenous communities, we'd be gathered in a lodge or in the teepee where, depending, there's so many diverse communities, but we would be sitting around a fire, so hopefully that thought will warm you up, and we'd be listening to one another, and we'd be talking and chatting. So I'm trying to make this a little bit more from a practical experience, I guess, or way of doing things, but covering a lot of the same ground, I think, that what we've heard, but more related to my own experiences and as, Indigenous populations in general, keeping in mind we are extremely diverse. I always say it's like saying Europeans. Lots of different languages, lots of different sort of cultures and places, geographies. So, we kind of lump that whole title together because it's a lot easier to say than all the different communities we have, but keep that in mind as well. But when we're looking at data equity, of course, it's the principles that that we use to guide ourselves in terms of how do we do this data collection, how do we do this research, and especially as it relates to people. But as both of the previous speakers talked about, is we know there's populations that are outliers that don't fall into the general population, or somehow they're subsumed by the general population. And so how do we do this through a lens of justice and equity and inclusivity? And that's really what I believe we're talking about today, or what I hope to talk about today. It's not an end goal, but it's framing a way to do this work from start to finish, and to make sure that we have the right people at the table, and that we are looking at things with a variety of different lenses and different perspectives. So just a little bit about my background. So I am, first off, I'm a Cree woman. I grew up in a traditional background, but I was also a lab tech. I was also a nurse, and then a physician, and I do family medicine. I've done emergency medicine. Worked in various different places. And what that's given me is a lot of different perspectives to look from. And that's really what we're talking about. How do we gain some of those different perspectives? Oops, sorry, I talk with my hands. Not French, but maybe should be. Excuse me. So looking from those different perspectives and trying to add in those pieces and tying in not just the data, because at the end of the day, as we've talked about, we need the data to inform the practice. So how do we do that? Because there is a bit of a jump, there is a bit of a leap there, and we don't always have people collecting the data that are the providers, and we don't always have vice versa as well. So I think trying to keep those pieces in mind is really important. So of course we know data is really important in terms of how to guide treatment, how to guide what we're doing, how we invest our time and our resources. And it can actually help us to improve quality improvement endeavors, of course, and multiple other things as well. I think, in terms of data, we also have to recognize that in our way of thinking, we think it's unbiased. We think that, oh, this is very clear cut, you can't argue with it, but the reality is very biased, and we need to recognize that and what our biases are going in for sure. So it's really based on our own perspectives, like even what are the questions we're asking, what is the data that we're collecting, what are the things that we're deriving from that data. So, and even what populations to study, these tend to be from a colonial lens, this idea of a scientific basis. But we really are just looking at it from one perspective, not from others. So, for instance, when we look at research around prescriptive medications, typically it's Caucasian males. We know that that doesn't always apply to females. It doesn't apply to Black people necessarily, or to Indigenous people for that matter. So we have fewer studies on other populations, and yet, as we've heard, some of these populations have disproportionate amounts of disease that they carry. So in terms of like chronic disease that they're burdened with. Certainly that exists in our populations as well. So who are we studying and what are we doing? The interpretation of the data. My son right now is looking at opioid crisis. So that's been a big topic in our family right now. I'm living it in terms of the population that I work with in the inner city and the populations that we serve in the north of the province where I work. So I should back up a bit. Where I work in terms of the north, it's almost the northern half of the province, greater than 85% Indigenous population, quite a diverse population, as I talked about. So even there, we're all quite different. Different languages, different cultures, all kinds of different things. And, you know, Northern Medical Services is the organization that provides all of the medical care in that northern part of the province, for sure. So lots of geographic distance, access is an issue, all kinds of different things there. So we're actually seeing the opioid crises in these small communities as well, and of course the things that go along with it. So from that kind of colonial lens, we in picture envision this opioid crisis as people who are making bad choices. People are choosing to be drug addicts, and so this whole idea now of, well, we're going to force people to get, you know, treatment. Well, science bears out that if you force people to do things, it really doesn't generally work. But what we're missing is the systemic issues, and our whole healthcare system is based on this concept that we make individual choices, when in fact, as was shown with the social prescriptions, a lot of these issues are actually systemic issues. And so we need to look at what are our systems that are leading to this situation, and why are some groups being treated disproportionately versus others. I mean, we have really good ideas, but these are the things that we need to consider. So when we talk about that opioid crisis, we rarely dig deeper into things like adverse childhood events and what are the predictors using those adverse childhood events for people who are going to be at risk for opioid crises. Well, anybody with abuse, anybody who's been removed, doesn't have a strong family tie. Over 60%, over 2/3 of the population of people who have addictions have those two markers as part of their adverse childhood events profile. We're probably creating individuals who are more at risk for opioid addiction rather than actually providing good treatment. So are there things we can be doing to prevent? And I think that's really where the data can help us to make those decisions, but also can help us to ideally be able to provide not only treatment, but preventative care as well. And things like homelessness, you know, we talk about, oh, we've got this big homeless problem. Well, again, what are the underlying issues there? Mental health is a big issue. Inadequate amount of housing that's available. People that don't have an income to support the housing costs. So we need to be digging deeper, and looking at that interpretation of the data is important. So it's not just those factors, but it's how we're doing that. And that's where, when we heard from Kai talking about that patient input, and from others as well, being so critical, because having that that variety, that perspective of having a variety of different people is really critical to that interpretation of the data, for sure. Also, how do we speak of the data? How are we portraying these things? So when we look at gender issues, for instance, and we look at things like domestic violence or intimate partner violence, we talk about victims or survivors. So, you know, just using that different term, a victim versus survivor, elicits different perspectives, a different picture. If we talk about something like violence against women, it seems kind of random, and yet we know from the studies over 90% of the perpetrators are male. So maybe we should be talking about men who are violent against women rather than violence against women, which seems so, you know, just random kind of thing. We talk about why does she stay versus why does he abuse. So I mean, it's the language of these things that we're really perpetuating certain concepts and ideas. That's just an example. It was an easy one to come up with. But we often use language to pathologize and blame the victims. So I heard that in the talk just previous to me with the Black population in Nova Scotia. We're pathologizing, we're saying, well, you know, and even in our communities, in Indigenous communities, we talk about suicide rates that are massively elevated compared to the general population. We talk about diabetes rates. So if you were to read some of these things, if I were to draw a picture in my head, I'd be thinking, well, we are probably, a lot of us are obese, we all have diabetes, and we're all depressed. But that's actually not the picture. And when you actually dig a little deeper, the vast majority of the communities do not have high suicide rates. In fact, they would be quite decreased compared to the general population. So there's certain pockets of things. So how are we analyzing and interpreting that data, and how are we utilizing it to empower people rather than to, which is the goal of data, rather than to blame, pathologize, victimize, those types of things. Using data to guide us is important as well. One of the things that I have a problem with is oftentimes when I look at the general population of our Indigenous population, particularly in the areas that I work in, we have the exact opposite demographic as compared to the general Saskatchewan population or the general Canadian population. So in Canada, we see a lot more of the tsunami wave, as they talk about, a lot more elderly population and very much fewer of the pediatric population. In our Indigenous communities, we have a large pediatric population. In fact, greater than 50% of our population are under 20 years of age, and we have very few elderly people in our communities. So the reality is what those data that's used to inform policies about how you're going to approach things for the general population doesn't really apply, and we're leaving people out based on that. I would guess that there are other populations that are experiencing the same thing as well. So how is that data being applied, and to what end and what purpose? So I think a lot of these different pieces are very critical when we're actually applying all of these pieces. Who owns the data? This is a big area in particular for our communities, but again, for other communities as well. And I believe that's part of where that distrust comes in, because you participate with the idea, and the carrot is always in any research project, in any data collection, well, if you participate, then you're going to get resources. Things will be better because you've spoken up. And do we see change? Not usually. And so people get burnt out with this. But the other problem is they never really get the information back. Nobody ever goes back to explain this. And we do have things like Tri-Council 9 guidelines. We've got OCAP principles. But what I actually see happening is still things like ethics boards may have one representative, Indigenous representative, or one representative from a different group, but they are very much in the minority. Often the processes that we have to get funds to do research, or how we come about that, are very fast in terms that people have to get things together. There's not that opportunity to actually initially build relationship and figure out what are the things you want to study and then make the applications. So that whole work that has to happen way ahead of time often doesn't happen. And so then subsequently you get these quick little support letters, get somebody to sign on the dotted line. And again, what are you really doing? You're going to a community or to a place where people are desperate for resources. They really want to show and highlight what's going on so that they can then better address things. Well, again, it's like putting a little bit of food in front of a starving person. Of course they're going to sign those support letters. Do they really believe that's the best way to go about things? Probably not. But they're willing to do what they need to do to get what resources they can. So we have processes in place that really aren't ideal. And I do know that there is work trying to mitigate some of these things, but really we're still seeing a lot of those types of things happening for sure. And then the other thing that is interesting about the data is, and who owns the data, I always find it very interesting when I look at researchers who start the whole process by doing various studies, whether we're starting at the university level, you get your first degree, and then you get your master's and your PhD, and this is all based on different studies, and then you're considered an expert in the field. But what about those people who have provided that data and who have informed that data? They're still seen, in our communities, we still, think of people as being seen as backwards, or we don't really understand, we're not the experts. So this idea of elevating individuals who are really just documenting the information to the level of expert, rather than the communities or people that have actually provided that data, seems a bit backwards in my brain, but that's how it is, and it seems kind of crazy. But also the rights to that data, to go back to it, to reinterpret, to utilize, often when we collect data, you can go back and ask different questions, but you have the data there. So this idea of data sovereignty is really critical, and how it's going to be used. What we've seen in many Indigenous communities, and again, what I've heard in some of the previous speakers, is how that data is used sometimes doesn't feel right for those communities. It could be used in a negative way. So some of the things I think about from a healthcare perspective is that it's not unusual that our data as Indigenous populations are included into things because they want to show, well, things are really desperate. We really need a lot more resources in this particular area. But at the end of the day, the people that are asking for that aren't serving those communities. So Sharon was right. In Saskatchewan, there's this idea that we have one health authority, but actually we've got two. And then we've got two jurisdictions, provincial and federal. So if you're a First Nations person living on First Nations territory, you fall under the federal piece of things, not the provincial necessarily. Sometimes you go into the provincial system. So there's a lot of back and forth and jurisdictional issues that occur there. The other thing in our province, particularly in the north, all of our communities have what's called transference. Transfer policy is enacted. So the communities actually run their own healthcare systems. Sounds good. But the problem is each individual community is responsible for their own community. There's not necessarily a collective. And the resources provided are markedly reduced compared to other places. So how the federal system runs in northern Saskatchewan is different than how it runs in Ontario, and that's different again than how it runs in BC. So this, again, idea that we're all sort of the same and treated the same is not the same, and it makes it more challenging for people for sure. We are seeing too that there is more economic clout and reasoning that's based on data. And so when you are making applications, there's an expectation that you are going to provide that information in order to be able to ask for resources and things like that. So do we have the resources within these communities to be able to provide some of those, or are the relationships there in existence to be able to get some of the data that they need to get? So there is, as you heard about earlier, the Indigenous Primary Care Council, and they advocate for acknowledgement, respect, and incorporation of principles of Indigenous data and sovereignty in all health data collection, management, and policy decisions. I think it's far more prominent in Ontario. We don't see it nearly as much in Saskatchewan, I would say. So again, this idea that it's kind of a little disproportionate depending on where you're at. In Canada, of course, data is governed by the Access to Information Act, which ultimately causes barriers to Indigenous people and communities and to their right of Indigenous data sovereignty. So we know, for instance, there are people that have difficulties finding out information, for instance, about residential schools. Who attended? What were some of the things that went on, or what even just physically located where people were. And then even health, a lot of the First Nations communities do not have access to their own health information. So one of the neat things we have in the majority of our northern part of the province is that we use the same EMR. And we do have some communities that are First Nations communities that are on the same instance as the general SHA, Saskatchewan Health Authority instance. But we don't have access to the data because that's owned in trusteeship by the SHA. So how do we overcome some of those barriers, some of those legalities? And it's not to say that the SHA doesn't want to share. There are ways. It just takes a bit of a process. But these are things that we have to work out and figure out, like, how do we do this in a way that's more useful for the patients, for the primary care providers, and for the general team that we're working as. And we are lucky in our northern part of the province because we generally do work as teams, primary care teams, where we have nurses, nurse practitioners, doctors, mental health workers, all as part of a broad team that are working together, which is great, but we all need to share this data. And of course, at the center of that team are patients and families that need to know about that data as well. So ensuring that Indigenous peoples have control over data related to these issues, including things like residential schools, health, and census, are more crucial to truth and reconciliation. This is a step that we could actually do to make things better and have people have access to what they need. So how does data then relate to colonialism? Well, we've seen a few things already. In terms of who has access, in terms of how it's interpreted, those different things. But also the federal government in the past has used information to perpetuate anti-Indigenous stereotypes. And of course that continues on today to some extent. And they continue to justify colonial policies and the oppression of Indigenous peoples instead of using the information to uplift and support Indigenous communities. And again, I would say this is not just Indigenous communities, there are other communities as well. Having said that, there is actual laws in place that allow for this to occur within Indigenous communities. So we're still considered wards of the government, like that, that kind of language is still in existence, which makes it difficult. So how do you remedy that? Well, the idea of Indigenous data sovereignty is a really good first step, and working with the communities to provide access to this information and governance over their own data. And then, of course, structures where these data compositories need to be rebuilt and rethought. How do we do this? How do we make it available to people? And making sure that the Indigenous communities are at the forefront. So an example of that is actually in New Zealand. There's a group called the Te Mana Ra'anga Maori Data Sovereignty Network, and it works with the government and universities for the protection of Maori data and for Maori to have full governance over their data. So that's actually nationwide throughout New Zealand. Excuse me. So perhaps these are the types of things that we may need to be looking at for sure. In Canada, institutions like including universities continue to be extractive when working with Indigenous communities. And this still is that colonial model that I was talking about, that we still have research projects that continue to uphold anti-Indigenous politics and stereotypes. And yeah, and typically those institutions will hold the data for the research rather than turning that back over to the communities. We are seeing a bit of shift. I'm seeing some researchers that are doing this a bit differently and will look at how to return that data to communities. So I think that's starting, but we probably need to replicate that on a much broader way of doing things for sure. And the other thing that we think about is going back to some of our traditional teachings. A lot of we did have ways of research, and we did have ways of learning things and knowing things. And so we have to look at some of those policies and procedures and how we went about it. Some of the things that I think about are what I call it, in our community would be called teepee teachings. But you could look at things like here in this territory, they had the Haudenosaunee Great Law of Peace, where it was how to work together without, to avoid conflict and to work for the betterment of the community. Sounds like a great place to start. I mean, that in fact is where the US Constitution idea comes into play, for sure. So there are things in existence that we could build upon that would be helpful for sure. So in terms of what my experience or what the experience has been of our organization, Northern Medical Services is a division within the Department of within the College of Medicine. And we get our funding both from the federal government and the provincial government and kind of have everything funneled through the university. Our main mandates include primary healthcare and healthcare promotion, specialist care, public health, research, and education. So pretty broad, but pretty holistic. And in some ways, the way I describe it is we're almost like the cross rungs between all these different organizations because nobody talks to each other and they're all running in parallel. And I would say this seems to be a general thing that we see in many places for sure. And one of the advantages of our Athabasca Health Authority is it's similar to the BC Health Authority, predating it by several years, where they've kind of already done the work to say the federal government, the provincial government have already made agreements and the bands are included on that. So they have those tripartite agreements in place so that they can work together without having to deal with all those jurisdictional issues ahead of time. And that's what they've done in BC as well. So we try to work a lot more with communities, and very recently what we've done within the last few years is actually hired a research position utilizing a community-based family physician who is working part-time with communities. And I thought it was so interesting when I introduced this idea and I was talking to our communities. What they asked for is they said, could we have like 15% of that so we could do what research we want? I said, yeah, it should be 100%. So that's exactly what we've done. We've really looked at it from a lens of making sure that we are getting the data that is being asked for by our communities. So one of the more recent kind of highlighted ones that just happened was one of the doctors in one of our clinics had noticed a patient had come in for chronic hip and knee pain. And when they did the x-rays, he saw some changes on those x-rays that kind of looked like scurvy. And so he did do a vitamin C test, and in fact it was a vitamin C deficiency and scurvy based. So we had talked earlier, we'd been having lots of discussions with the local band about food security issues. And so we talked, this came up because of course that became known in the community. And the chief and the band decided that they wanted to do a study on just looking for vitamin C levels and what's going on in the community. What we actually found was that there were 27 cases of 51 people tested, 27 cases of scurvy in our community. Who thinks we have scurvy in Canada? I mean, it's ridiculous, really. But that was a really good way of working together, and we had done a lot of this work ahead of time to, when something came up and the band decided they wanted to act on this, we were able to do this. We didn't have to ask for funding from any organizations, so we didn't have to make any applications that way. We could do the ethics approval through the university and just proceed with that and utilize that. So, and now, because we also work with our public health, with our medical health officers and such, they were involved in the initial research and data collection, but now we're looking at, okay, how do we deal with this and what do we do? Is testing the answer? Probably not. It's a difficult test to do. It requires, it can break down in light, and so it's going to have to be sent out. Probably doesn't make sense. Do we just go around handing out vitamin C to people? Probably not. We could. That would be one thing that we could do. But the other thing to think about is when we come back to that idea of food security that the band had brought up in the first place, some of the things they talked about was the difference in cost and price for food stuff that they were able to purchase in the northern communities as opposed to down south, and the difference in cost of those things. And one of the teaching tools that I use is I talk to our new doctors or people that are training to be family doctors and ask them, okay, what's your prescription for a diet, for a diabetic diet? And they'll write out this beautiful, beautiful diet that we should all be eating. And then I tell them, okay, can you go price that out at the local store? And find them. First off, can you find what you've asked for? And secondly, what's the price going to be? So they do this. And of course, it's always a little startling to find out we don't really have a lot of those products. So what could you use? And then when you start pairing that with like, well, what do people get in terms like of wages, or if they're living on assistance, what are the housing costs? So what's the reality of that for people? We don't often think about how do we apply a lot of those pieces. So we have to think about, well, what might that look like? From the community's perspective, one of the other things that they brought up is that there's a move away from traditional foods for the younger population. And so they're not eating as much of those traditional foods. And then when we look at climate impact and the implication on foods there, it's been massive. We don't have the same access to those traditional foods, whether that's animals moving out of the community, whether that's damage done to plants, there's all kinds of different things going on. So when we looked back at the traditional diet, there's actually lots of vitamin C in those traditional diets, but we don't have that anymore. So those pieces that the community was able to bring in and the direction that they gave really was critical to how do we manage this. So now we need to be looking at, maybe we need to look at some of the policies around food and food acquisition, and how do we get food in there? How do we maybe get our nutritionists to learn a little bit more about traditional foods and what foods might be good things to include in diets and things like that. So that's just an example of how you can actually do these things. The other advantage of having our researcher as part of our group is that he lives in the community. The people know him, and that relationship is there, and continual fostering of that relationship is really important. But he's also a conduit between our group of physicians that are practicing in that area, which are not fee-for-service, by the way, because we also find that that is not the best way to really deal with health. But it's also a conduit for those residents and students that we're bringing up as well. So really fostering that capacity building within our profession, but also within the community. We want to foster that with students. So another thing that we were working with lately is we do a lot of kind of remote technology kind of things. And so we have a scientist that works with the Canadian Space Station who is working on portable MRIs. And he's now teaching some of the basics of science around what that is based on in some of our northern schools. And the idea is that those kids will have those basics for science, can go on to get more training or to go to university, whatever things they want to do. But they actually are going to already know how to fix those portable MRIs when we actually implement them. And so we don't have to rely on outside sources to do that. So let's build that capacity within the community. Let's see what we can do to make this really work for people. So those are the kinds of examples of things that we can really do to tie this data into how we can actually implement within community. What does this really look like? What are the potentials here? And the potentials are huge. And it actually makes it far more fun when you're actually doing these things, because you get to be with people and talk with people and really get to have different ideas and opinions. The other thing is there's less burnout, because guess what? You're actually working with a whole group, so nothing rests on any one person. We need to work together on these types of things. So those are the types of things that we really have tried to implement and work on in terms of data and data collection and utilization of that. There are a variety of different groups that we work with. One is the Health Quality Council, Saskatchewan Health Quality Council, for things like quality improvement. They have great resources and great people that are able to help us out, again, as a team, working how we're doing some of these things for sure. We have groups like the NEAR group, which is the Network of Indigenous Health Research. And so we're able to do that capacity building, identify potential researchers who might want to work with us and kind of be part of our team or part of our communities, or who already are part of our communities and that we can incorporate into the team. We, of course, have the luxury of working with the universities. So from the College of Medicine point of view, we can bring in different students and researchers. We can access public health. We can access a variety of different places, because Indigenous health crosses many different pathways. So even in geography, they have people who do human geography studying Indigenous health. They have, in education, they've got all these different areas. So you can really pull from these different places and, again, connect to the community in a much more meaningful way. Of course, another group that we're working to connect and working with communities to see if this is something they want to pursue is the Canadian Primary Care Sentinel Surveillance Network, which is something that's done in many provinces, but the data is collected and de-identified to give better idea around how primary care identifies and addresses all kinds of different issues, particularly chronic disease issues, and how we can better do this in terms of primary care, and to facilitate innovation and excellence in terms of how we approach some of these things. So there's a lot of different ways that we can approach this, and it can be really fun. And I think, I heard before, the data nerds. I have to say I love data, I love stats, but the reality is we have to make it more fun and exciting, and it is fun and exciting when you're able to do these things. But building that capacity within communities, within our researchers and within our providers, I think is going to be the key, and building it as a team, inclusive, and at the center of that team are the patients and the families and the communities, and how do we incorporate that? So that's just some little practical examples of what we're talking about and how that might look, and hopefully that will be helpful to give you some ideas about how to get recharged and ready to go and put this all to use. So, and hopefully I won't hit the mic again. Anyways, thank you.
Thank you. That was excellent. Okay, so we'll open it up for questions, and then following that, we'll have our lunch. So Steve, would you mind coming to the front? Thank you. Okay, go ahead.
Okay, so much better. I'm Robbie Spring. I am a patient advocate and also a breast cancer survivor and care partner. I've always worked in like the health and life sciences space, and now am doing both advocacy and working in the space. I am a data nerd, so you can count me amongst that. I have past work experience in the informatics space, and I also worked with the Danish government. And so when you talked about the federal, provincial, territorial table, I had a speaker in from Denmark at like in the middle of COVID, this guy Hans Erik, and he was talking to everybody that attends those meetings on having a universal identifier across Canada. And Stephen, I was just wondering if you've made any progress, and then I have a follow-up question. Sorry.
Okay. Yes, we're good. Yeah, good, great question. Really, probably a little geeky for many of our people in the audience, but so there's been talk for many years of a nationally unique identifier. It's a complex, fractious, politically sensitive issue, especially in North America. Love Denmark. They have a different political dynamic, which there's not as much opposition to those types of things. But in the age of, you can see the misinformation, disinformation, the concern, the lack of trust in public institutions. That's sort of the context we work within. So getting to that truly national unique identifier, we still talk about it, but I quite honestly don't think it's possible. Having said that, I think there are ways to get at uniquely identifying everybody in an appropriate way that doesn't require a single national unique identifier. There's lots of ways to flag and tag. Everybody has a health card, or most people do.
Right.
And so there's ways to get at that without creating a net new indicator, or identifier, excuse me.
Right. So is there progress on like federating those systems and having them speak to each other? Because like you don't need matching systems. You really just need you're talking about an API. You need them to actually like match.
So yeah, very doable. I'll share with you. So in case you haven't caught the accent, I'm originally from Newfoundland. So, oh my goodness, and I'm really old. 25 years ago, we put in what we call an Enterprise Master Patient Index, which is a way to track Newfoundlanders' MCP card, provincial health identifier. But in that registry, we also had space to track any other identifier you might have. So if you were a veteran or an RCMP officer, or you had come from a different jurisdiction. So we literally, 25 years ago, were able to track and link in case we needed to pull information. We rarely used it because of the privacy implications, but it was available to. So that technology's been around for decades. It's just a matter of the willingness to allow it to happen. That's where the discussions are these days. So one thing I'll add, Bobby, that might be of interest to you is we, as part of that new money CIHI has received, we are creating a pan-Canadian data governance table, bringing everyone to the table. Let's agree on the rules of the road. How could we share? What will those rules look like? Essentially creating the guardrails to enable this type of work.
Okay, well, that's great to know. The other piece is that I am a key collaborator with Rethink Breast Cancer, and they have a campaign right now called Make Me Count. And that's because there's actually like no way to track across Canada how many people have metastatic breast cancer. There's an issue with the coding. So I wanted to bring it to your awareness, because if somebody is diagnosed as early stage breast cancer and then they end up recurring metastatic, like the hospital will know, but there's a coding issue. And so they're actually like not counted. So we don't know anything to do with the long-term implications of like, how long do they survive? How much does their treatment cost? So I didn't know if you were aware of it, but I also wanted to bring that up.
Yes, sadly, yes, I am aware, and there are many other similar conditions.
Yeah.
It's a huge gap. Lots of talk about it. It's complicated. I was chatting with a colleague at my table around pulmonary disease and registry and tracking. It's the same issue, different disease. And it's just putting in the rules again. How do I link those people who are in that registry for cancer or whatever your condition is, and allow us to link that to other data sources? We're actually doing that, but it's very piecemeal, and it's very much driven by getting the permissions in place. A lot of registries don't have that, unfortunately. Happy to talk with you more about this over lunch. Maybe. Okay. I'm just conscious of others.
Thank you.
Okay, do we have anybody online?
Yeah, thank you. Is it on? Yeah, thank you. Data is definitely not boring. There's a lot in data. Veronica, I'd love to chat with you over lunch. You said so many things about the drug poisoning crisis that echoed what I said yesterday and what the family experiences. I represent families with Mom Stop the Harm who've been affected by the drug poisoning crisis, including Indigenous families. So let's chat. But I have a question for Stephen or anybody else who could help me with this. What do we do when governments give us incomplete data, when they hide data because it makes them look bad? Like an example, I mentioned that briefly yesterday. Tara Moriarty from the University of Toronto is an incredible data cruncher. She does a lot of work around COVID. And when she looked at COVID data across the country, she discovered that in Alberta, there's a lot of excess mortality, like deaths that are not explained. Do we have to go anywhere? Deaths that are not explained by common conditions, like that are above what we would normally expect. Yes. Oh, this is this warning they told us about on TV? Okay, it's just a test. So there's in Alberta, there's a lot of excess mortality in an age group that is typically not affected by COVID. There was 15 to 40-year-olds, and an age group that is more affected by drug poisonings. Yet, when we get data from the Alberta government, it typically what they submit to the Canadian Health Agency is their initial data. It goes up by 10 to 20% later, but that initial data with the Canadian Health Agency is never updated to the complete one in the documentation. And there is a suspicion in the community that they're deliberately delaying the release of the data because it looks really, really bad. Like 2023 was the worst year on record ever for drug poisoning in Alberta. So what do you do with governments that you know they have the data, they don't give you the complete picture? Is there any kind of leverage that we as Canadians have to hold our governments accountable? They owe us that data. Like as families, we need to know why our loved ones died. Thank you.
I think that's mine to at least begin to respond to it. Certainly if others have thoughts on it, I'd welcome it. That's a tough question, but I would remind you of the final slide I put up around the Healthy Data Collective. I said it almost tongue-in-cheek. Everyone thinks governments are accountable and responsible for our health data, and they're actually not. It's just an assumption that we think because they fund healthcare and they deliver services that they're also on the hook for the data. And the truth of the matter is, there's nothing in legislation or anywhere across the country that stipulates Minister of Health is responsible for your health data. And so this is where we get back to the notion of the Health Data Charter and demanding as Canadians, that's my data and I want it. And what are you doing to make it more accessible, understandable, and available to me or whoever I choose to share it with? I think this, and I describe that collective as a bit of a grassroots movement, but it has to be Canadians. Steve from CIHI and many other roles I've fulfilled in health administration, health data, like we're just part of the system. And we've been trying for decades, quite honestly. We've made progress, but we'll never get to that level of accountability, which is what I hear and what you're describing in that challenge. I don't know how deliberate it is. I wouldn't describe ill intent. I'm always amazed at the inability of government to be effective, even without malicious intent. And I don't mean, and I'm a former public servant, so I can say that, I think, without being considered hypercritical. But I actually think this is on us as citizens to say, this is not good enough. I expect better. And I think many politicians will be surprised and maybe relieved to learn that it's not theirs to control, but they can't be an impediment to it. I'll stop there. I don't know if others have thoughts.
Okay, thank you. We have one more question over here.
Thanks very much thanks for all the presentations. That was great. My question is for Jamal, actually. In the slide that you presented that had the graph showing the decline in COVID-19 cases among the Black community once the data became available, I also noticed on the same graph that the numbers in terms of the South Asian and Southeast Asian communities actually increased at the same time. I'm just wondering if you have any insights around that. I mean, I find it really interesting that, you know, there were Latin and Black communities that had a major decrease, but then Asian communities that had a major increase at the same time.
No, I think that's yeah, it's a very interesting to look at all the trends that are there, and I'm happy, yeah, to I suppose speak to what I can right now, right? And one of the things I suppose that we're talking about is the responsible interpretation of the numbers, what I was, you know, hoping to focus on, right, was how the pandemic was, or I suppose the interventions that were working with Black communities. I have it up here as well, and you know, at the same time, if we remember, that was when the second wave of the pandemic, or the biggest one, 2020, was right around the fall. I can't provide any clear information right now, right? I want to be very responsible in providing any interpretations that I would have. So, but that's something that, you know, I hope someone could provide my information and stuff. I would love to go back to the team, and I would need to also engage with organizations that focus on those communities to get a consensus on. But yeah, no, I think it's great to then see. I think that what the broader message, though, of it all is what I can speak to, is that the interventions worked for Black communities. And what we see, even if we look at the rate ratios across the years that the data was collected, is that there's greater variation that's happening in communities where there are no equity-based efforts happening, right? In Black communities, we're able to see, sure, you know, of course, a wave happens, everyone's numbers are going to be fluctuating dramatically, but we're able to see at least a containment for the Black community as a whole here in Toronto. But we weren't able to see that for other communities, you know, perhaps simply because, you know, there wasn't enough resources provided for those community organizations to mobilize in such ways. But we were able to see efforts. I'm not going to say that there wasn't anything for community organizations to do things, but what the Black Health Equity Working Group focused on is being able to, you know, group together and mobilize and gain the resources. So I think what the message at least should be, in absence of me being able to provide a clear answer, is that we need to ensure that, you know, all different types of racialized communities have the ability to come to a space, look at the data, understand what it means, and have the resources then to provide the interventions so that an answer can be given right now, right? I think that's the broader message of what we even try to say is the work that we do on Black communities is specific to the context, yes, of you know, Black communities themselves, but not to say that there aren't lessons learned, you know, that are useful for other communities as well, right? Racism and other forms of oppression, right, affect everyone uniquely, but then I think we all come together to the same understanding, though, that we need to be able to use data to identify and address these issues responsibly. So yeah, something I will be looking back into, and I hope again someone can provide my information, and maybe we can talk about this later for sure.
Thanks very much.
Okay, thank you. One more online.
So this question is actually for all panelists. And how can data equity initiatives also address social determinants of health? So whoever would like to start.
Yes, I'll start. I don't know. Oh, there we go. So I think one of the things, like whether we heard about the social prescribing data that involves patients, the common theme there is there's multiple layers to what these issues are. That when you actually look at the health data, it's a symptom of all these other pieces, which are in fact social determinants of health. So certainly I think that's especially where we can really collect data in a useful way, but that's also where that patient-informed approach is really critical. I think it's also where we need to look at populations. whether we're talking Indigenous populations like Northern Saskatchewan, whether we're talking about, the Black community in Nova Scotia. I was even thinking when I was listening to both of the previous presentations, our Black community in Saskatchewan is very different than the communities that we see here in Toronto or in Nova Scotia. So again, diversity amongst all the different groups means that we really have to talk to the people to get that lens of how does this relate and what are some of the issues that people are experiencing. But I think really that's what we would probably filter down to is social determinants are critical to all of these pieces, regardless of who you are, where you are, but we need the people, the patients, to be able to inform us of how those ties exist and how we can use the data to get that support.
Thank you, Veronica. Sharon, did you have any comments?
Yes, I think I can add. When we think about, having data that finally shines a light on inequities and disparities, we can make those connections between, for example, racialized communities, or in the case of Hawk, African, Nova Scotian, and Black communities, and how their access to health services affects their health. Without the data, we don't know that. We don't have that information, right? How does race affect their education and their educational attainments and outcomes? Clearly, there are disparities and inequities in the education system. Housing, same. Income, same. Coping strategies, same. When we look in Nova Scotia, it may interest you to know that we were the first to have culturally specific COVID vaccine clinics, the first in Canada to do that. And we had to fight again, advocate very strongly for that, because we knew that one size would never fit all, and vaccination with populations who have historically been traumatized and have been abused by the health system, for them then to feel comfortable and trustful toward getting vaccinated. Again, with social media telling them things like Black people were immune to COVID, believe it, that was out there. We had to fight all of that in order to have culturally specific vaccine clinics. So my point in my presentation around our cultural competence framework is about how you do it as well. And that is by having culturally specific responses to high levels of education, or low levels of education, frankly, and educational outcomes that should be improved, health services that should be improved, and so on and so on. So for me, health data that is governed correctly, that is fair and equitable and reasonably transmitted or transferred to people, is inextricably linked to improved health outcomes.
Okay, thank you, Sharon. Did you have any last minute or last comments, Steve or Jamel, before we break for lunch?
I guess what I can just add just at the very end is community governance, of course, is in this context, we're talking about bringing people in to understand their health better, right? And the interventions we're trying to use. I feel like I spoke about that enough, so I'm not going to emphasize that. What I'm going to try and do right now is I want to also enlighten people on the fact that social capital is another, outcome out of building community governance mechanisms, meaning that the more that you involve people in, whether, they're government institutions, health institutions, but they're going to be coming in and you're going to be driving conversations about data at first, right? Or maybe their health at first. But then slowly over time, what we are going to be able to do is build trust, right? Social participation into these programs and services that we're trying to provide. And then also then providing more confidence in these institutions. And that's what we want to see as a whole, right? People being able to navigate through the different services that we have available, because sometimes there are so many things out there that people have no idea about because they just aren't engaged, in the right ways. And so what our responsibility is to build trust so that people are more aware. And then all of a sudden, when you have a new housing program or a new housing initiative or new food services in certain areas, people are going to know about it. People are going to actually be able to engage and use the resources that we're trying to provide them. Because as much as we try and construct these things, we also need people to trust in us, right? That's something that I touched on. So community governance, yes, is about these data pieces, and it's very important that we understand how that's going to be managed, and communities are able to decide those things, yes. But then as a whole, what this means is that communities become a part of our larger, institutional structure on governance, right, as a whole. And I think that's a really important piece, that when we talk about the social determinants of health that touch on, income, on education, on housing, all of these different pieces, we got to start somewhere. And I think community governance of even health data, the way that I'm speaking, is a start. So I'd like to just get that.
Awesome, thank you. Steve, and then we'll go to Leah for our last comments.
I'll be brief. I think the empowerment that comes with everyone having access to their data, whether that's as an individual or as a very focused community, is really important. And so at the end of the day, the challenge comes, how are we going to pay for all this? So the good news is Canada is uniquely positioned because we believe in the Canada Health Act. Most people believe, how much money you make should not affect your right to access care. We're all in this together. I love that about Canada. We do incredible research. It may be focused on old white guys like me too much, but we have very strong, sophisticated research infrastructure in this country. We're also a global leader in AI, If we can sort out the issues around more granular data and do it in a way that everyone's comfortable with, we have a huge opportunity. It's an economic opportunity in addition to all the wonderful things we've discussed about today. That's the thing that might tip it with politicians and senior decision makers. At least that's what I tell myself.
Okay, thank you. Okay, Leah?
Just thank you, everyone. This was such a rich and insightful conversation. And thank you, Jamal, for naming social capital, trust, social trust as being really some of the most important outcomes of proper, deliberate, long-term, ongoing community governance. And I just wanted to make a couple of quick comments and pitches. So, because we clearly have some data geeks in the room and online. So it's for everybody at large, but there's going to be more, I think, accessible versions of this coming in the not distant future. But Steve mentioned that CIHI has been working on health data standards, so health data standards framework. So starting with the primary healthcare record. So what would a record look like for all of us living in Canada whenever we go see a family physician or a nurse practitioner or primary care clinic? And that draft, this is going to be an ongoing iterative process, but that draft framework and those standards are currently available for public consultation online. So if you Google, it's on CIHI's website, so if you Google Health Data Standards Framework, and sorry, Steve, but I have to make it public, so hopefully you don't mind. Please go forth, and the documents are quite technical, so that's why I said, as they currently stand. So it may not be for everyone, but if certainly for the Robbies out there and anyone else, Veronica and others, but everyone take a look at it who's interested. For some people, it may feel like, this is too much to respond to, but please be aware that's happening, and it will be an iterative process, and I do think there's going to be sort of more accessible versions of that would be, for people who maybe get overwhelmed by all of the technical information in those documents, it would be a little bit more accessible for them to be able to provide their input into these really foundational standards. So it's exciting work. Applause to CIHI for this work.
and for starting the public consultation on that. And then I just wanted to briefly also just make a comment on the question that has, that I've heard forever, which is the who owns the data question. And I know maybe it's different in different research studies, but certainly when it comes to personal health information, the Supreme Court was loud and clear. It is our data. When it's our personal health information, it's all of our data. The records, no, that's the providers, whether they're digital or they're hard copy or whatever the case may be. But that information is ours. We're interacting with that healthcare provider because it's a trusting relationship. We want, we're sharing that information so that we have a continuing interest in it because it's our health and well-being. And so that is the answer to that question. When you're looking at First Nations, Inuit, Métis nations, et cetera, then we're getting into that collective concept of ownership of that data. It's not just the individual personal health information that is owned by the person, but it is the community itself. And I just wanted to put a pitch out there through the work of this summit, through the action planning that we are going to be starting with the breakouts today and continuing tomorrow, we formed working groups. And one of those working groups, and we formed 3 of them, 2 of them are still going actively because we were really, seeing we need to change the underlying factors that are needed for health system reform to really be able to be responsive, to understand and be responsive to people's needs across the country. And so health data was one of those working groups, and it was established back in 2019 when Eric Sutherland was at Kai and came and presented to us. And he joined that working group and helped us with patient advocacy groups create a Declaration of Personal Health Data Rights in Canada. It's an imperfect and living document, but it's really focused on the personal health information side of things. It started with that question. We literally asked ourselves, because we've heard it so many times, who owns the data? Right? And what does that mean for access? That was the start of the conversation that led to that declaration. And it's basically 10 or 11 different principles, starting from that Supreme Court decision, looking at things like what they've done in Europe with their data laws. Sorry, I've blanked out on the name right now. And we put together, okay, what are those 10 or 11 different core principles that need to be in place for people to feel good about their health information, their personal health information being shared, whether that's clinically, for research, for quality improvement, for system improvement. And it's a starting place, and it's been endorsed by over 30 different patient organizations across the country, as well as many individual patients. If you're interested in taking a look at it and maybe adding your endorsement to it, sharing it, using it as part of your work, you can find it actually. If you go to the Patient Summit webpage, you'll see the working groups are mentioned there, and you just click on the one for health data, and you'll see that information, and you can sign up and all that good stuff. So thank you so much, everybody. And I think we're moving on to lunch soon.
Yeah. Thank you very much. We know there's lots of discussions going on across Canada, and we know there's still a lot of confusion and work that needs to be done. But I think having these discussions help us become more clear on where we're going and how we're getting there and every single detail of that. So I'd like to thank the panel very much and the 2 online. Thank you very much for providing, I guess, your input and knowledge and expertise to the discussion. So thank you all. And now we're having lunch. Oh, sorry. Thank you.